Hello, everybody. Welcome. I think we are ready to go. Um, Good morning, good afternoon, good evening for for everybody. So welcome to my webinar, and it's going to be 3 hours. And as far as I know, we have. Let me just put it right here. Okay, so we have a lot of beginner new doctors. So I was asked to talk about basic things and to get through everything as normally we do. So I try my best to give you the a lot of information, the most possible information about the aesthetic driven protocols created by Dr. Pitts and with our system. All right, so let me just, yeah, okay, it should be fine now. I have just gotten a new MacBook, so I had some issues with that, but now everything seems solved. So yeah, we have. You can hear I'm in my home, and we have like two dogs and a cat, so you will hear some barking during the lecture. So sorry for that, but it kind of makes this more special during the pandemic. And obviously, our cat is not barking. It would be even it would be a miracle, obviously. So let's talk about a little bit about myself and my background. I was graduated almost 27 years ago in 1994 at the Semmelweis Medical University in Budapest, Faculty of Dentistry, obviously. And right after my graduation, I started to work at the Department of Orthodontics. So basically, though I took my orthodontic specialty in 2000, right from 1994, I already worked as an orthodontist, and I wouldn't do anything else. I have a lot of implantologist friends, periodontologists, everybody, aesthetic dentists, and admire their work. But I would go for orthodontics again if I had to restart. And from 2011, basically to 2011, I worked for different private companies, and then I made my own company, which is called Csiki Orthodontics in Budapest, in Hungary. I practice in Budapest. I live just outside of the city because it's too crowded and too loud for me. Um, it's been a while. And I also have the honor to practice in Milan, in Italy, where I started to work in 2005, thanks to a great friend of mine. And now I work with two of my general practitioner friends who are I'm their orthodontist. They have 3 offices, and usually I work there 5 days a month. And it's always a pleasure to be there. Obviously, not every month because I don't know if you know, but everybody is on vacation in August in Italy. So basically, Milan is like a ghost city. So it's totally empty. So and all the dental offices are closed. And I'm also since 2018 the honorary associate professor at the University of Szeged in Hungary. I don't know how many of you were in Budapest. I think it's one of the most beautiful cities in the world. There are two parts. Is like the hilly side is the left side is Buda, and the flat side is Pest, and they got united in 1872. So if you have a chance, I hope we will have some European Pinnacle in the future or some meetings. But if you have a chance, just come and visit because it's really a gorgeous city. By the way, we were supposed to have together in last October with Dr. Pitts one-day seminar here in Budapest, but and hopefully it will happen as soon as the pandemic will be over, and we are just hopefully coming out from it. Milan is a great city. It's like it's fantastic to be, to live there and to be a part of the Italian lifestyle for a couple of days or almost a week and months. And it's also, famous for shopping, culture, food, this kind of stuff. So probably all of you, Italy. So it's a great place. So I'm really honored to be able to work there. And this is my office in Budapest. This is the waiting room, and this is one of our chairs. We work on 4 chairs right now, and plus a consultation room, and then we have a photography room as well. And so we have everything we need there. This is my team, and is my fellow orthodontist, Dr. Levente Szegedi, and those gorgeous ladies are my assistants. She's Alexandra. She's my practice manager and my personal secretary, my right hand, left hand, and middle hand. This is my older son, who is just enters into dental school, but he comes to work with me and assist with me. This is how I started. Actually, he will be the 4th generation if he graduates. And she's also not just an assistant. Her name is Claudia. She's also our patient coordinator. And this is Balázs on the right side. He's our photography assistant. So this is my team, and without them, I wouldn't be able to speak for you here today. So I can't thank their work enough. And we really, every day is we enjoy our work and be together in the office and work on our patients. This is the University of Szeged, which is where I teach. Since the pandemic, we teach online, but I used to go there twice a month, and then once a month to teach postgraduate students and also graduate students. So this is Budapest right here in the middle. And when I go to Szeged, and it's close to the Serbian border, so it's south from Budapest, and it's also a beautiful city, and it's about a 2 hours drive. Hungary is a very small country, so it's like from south to north you can drive through like in 3 hours. And yes, this is the University of Szeged where I also teach, and I love teaching. Okay, let's see the orthodontic appliances in my career. So obviously in 1994 I started with removable appliances. So I still use biomaxillary appliances till today. And from 1994 till 2004, I worked with conventional straight wire braces appliances. So I went through the usual evolution of an average orthodontist. I also worked with lingual braces. I started with it in 2000 and finished with that in 2017 because it broke my back, and I wasn't that satisfied with my finishing as I did with my vestibular braces. And since the aligner systems became better and better throughout their evolution, so I decided only to use Invisalign, and Happy Smile is a Hungarian aligner company. So today I do use aligners. Honestly, it's like 90% of my patients are PITS 21 cases now, so braces, and around 10%, maybe a little bit more, 15% are aligner patients. And yeah, and I the main thing about my career, this is why we are here today, is passive self-ligation. So I started to work with passive self-ligation in 2004, and I'm a speaker from 2008. I also use orthodontic microimplant stats since 2006. I started the usual way, which means that I wanted to put screws everywhere I could, even on the legs of the patients, and then I realized that we don't need that much that many screws. So today I really use them only if I have to, but they are a great addition to our work, our profession, and those who watched my dear friends Dr. Wasim Buzid's webinar 2 weeks ago. I think, yeah, you could see, wonderful cases with that from him. All right. Courses in the orthodontic programs. Basically, till 2007, I went to take courses and programs in Hungary and Europe. My ortho program was at the University of Budapest. And then from 2007, I started to go mainly to the United States. I took part in office courses. I went all to visit all the big names, and the highlight of my career was when in 2012 I took part from 2012 to 2014 into the Pitts Masters Continuum program. And it was the first program, and it was really interesting because basically what happened that we were participants, but we were already all of us lecturers. So what happened is that it was a great adventure for us, because we kept learning from each other, and mainly from Dr. Pitts and Dr. Brown. And I'm a Pitts Progressive Study Group member, the study group of Dr. Pitts from that year too. As a speaker, from 2008, I became the passive self-ligation speaker in Hungary. And then from 2014, I speak for Ortho Evolve and Ortho Classic. Ortho Evolve is our group of speakers of Dr. Pitts. And obviously, the turning point of my career was when I met with him, I will just call him the boss, with the boss Dr. Pitts in 2008. So it's almost, in May it will be, no, actually in April. So this month it's 13 years now. So time flies away. These guys are my ortho icons. Obviously, Dr. Pitts, and the other one is Dr. Duncan Brown. Dr. Pitts practices in Reno, Nevada, and also the Ortho Classic facilities is in Portland, Oregon, in McMinn, next to the coast of Portland in McMinnville. And Dr. Duncan Brown is the other guru. He practices in Calgary, in Canada, and we gave a lot of lectures and courses together. So Dr. Pitts is the clinical director of Ortho Classic, and he was an orthodontist already when I was 2 years old, so in 1970. And throughout his career, you believe or not, I think today, up till today, he's been treated more than 55,000 cases. So it's, again, 55,000 cases. So I truly believe he is one of the most experienced orthodontists not in the world, but in the universe. He's a professor of the University of Las Vegas, associate professor right now. He created his Pitts Progressive Study Group in 1979, actually became international in 1980. And the main thing is that he was focused on aesthetics. Aesthetics is underlined here, you can see, and occlusion since the beginning of his career. Yeah, I lectured, in Orlando at the AO. We had our first Pinnacle European Congress in Milan, which was a great honor for me. Then we had in Warsaw in Poland, which was also a fantastic venue. And then the latest, we were supposed to have our last year and this year to our European Pinnacle in Barcelona, but instead of because of the pandemic situation, we had to we did at the end of Virtual Pinnacle virtually with all of my great fellow speaker colleagues. And this is the group of the first Masters Continuum series. That was, as I have just told you, that was one of the greatest adventures and fantastic, things in my life, and I really learned a lot, and I keep learning a lot from Dr. Pitts and from our group and my great fellow speakers and friends. We have the Peace Global Master Series where I also teach, and that's me with it's like when my older son saw, actually it was a younger picture, and he looked at me. He was around 10 years old. Now he will be 23, and he told me that, Dad, you used to have hair, and I said yes, but it's like so that was me in 1997 when I was graduated at the University of Budapest. And as a newbie, and obviously, as I have already showed it to you, I started with traditional orthodontics. So it means that I did a lot of bicuspid extractions. I never used headgear, but I used a lot of rapid parental expanders, like mostly Hyrex that time. So I went through for my first in my first 10 years. I did a lot of traditional treatments, and obviously I was trained, as we all of us were. I mean, at least my generation, to do orthodontics for function. And unfortunately, what I see still all over the world when I travel and when I lecture, that it's it's kind of like orthodontists are really concentrated on the function, and they want to have the class one occlusion, which is an absolutely good thing, and I fully agree with that. And but on the other hand, it's like, they check the mouse. They always check the mouse of the patient, just the mouse occlusion, cephalometrics occlusion, and it's always like that. And then uh, it's something like they tell the patient, okay, we are ready, you have a great occlusion, so okay, we remove your braces, and then the patient is happy, okay, yes, and most of the times is tired of the treatment, and then they remove the braces, and then, okay, so let's see your smile after they remove the braces of the patients. And so I had this I was in this situation, let's say, and I was about to tell you that I was having this disease. So just I cared about occlusion, and I was only trained to do orthodontics for function. Nobody really talked about aesthetics. And honestly, I wasn't really satisfied with, and I already, after 10 years, I saw a lot of cases how I ruined with the non-bimaxillary protrusive face type, with bicuspid extractions, how I ruined the faces of and how I made them alter the faces of my patients, which really disturbed me, and I was searching for new possibilities. And then I went to a course of passive self-ligation. Actually, it was an advanced course in 2004, and then I really liked the idea and the light forces. The whole thing was much more biological, and also I like the more the let's say the aesthetic driven, or some kind of aesthetic driven approach, which wasn't aesthetic driven that time yet, only by Dr. Pitts, and later, obviously, when in 2008 I met him, then it became to me obvious that this is why we are here. So in 2004, I returned back home in Budapest from that course, and then I decided, okay, I finish those cases with braces, with traditional braces, but every new case I started passive self-ligation. And I learned from Dr. Pitts, and what I do and what we do now today is we do orthodontics for aesthetics and beauty. Because this is what, we don't, as we do say, we don't save lives. Actually, sometimes we do, especially, mothers' lives. But we change, we have the ability to change the life of our patients. And the demand for aesthetics is higher and higher everywhere. So basically, I kind of found my home, with this aesthetics driven orthodontics, which we do for the beauty of our patients, because it's very important to give them a full lips and a beautiful smile, and we can really make a difference in their lives, and we have to realize that. And beauty is very, very important. It was always very important throughout being humans, and but it starts, these slides are about that beauty starts from a very young age, and it is with us, or it follows us throughout our whole life. And I always show this lady. Her name is Iman. She's a supermodel. She's on in this picture. She's really over 60 years of over 60 her age, and she still has a full smile, and this full smile which makes her look really young. Obviously there were other interventions on her face, but it's like it's a big part of her face is that full smile. We call it the 12-tooth smile, which because it goes from first molar to first molar. Typically what we see throughout the world till today, unfortunately, is that orthodontists, if they take a look at the smile of the patient, then they typically create a 6 or 8 tooth smile, not a 10 or 12 tooth smile, which makes a huge difference. So I think most of you have already realized that our patients today have the request for aesthetics, and what they want is a perfect smile. And this is and it's like I always I joke with this thing during my seminars in person, that nobody wants to change their AMB or SNB angle. Still, orthodontics is still, big part of orthodontics still about cephalometrics, and they don't care about cephalometrics. They care about their smile, and they don't want to change their AMB angles or angle. So this is just some of my patients, just to show you how we can create or change their lives. It's like obviously there is an occlusal cant here, and she had a crossbite on the left side. And this is the final, result, and with a nice smile arc. We're going to talk about obviously the smile arc and the full smile. Another patient, before, after, and then on the right side you can see how we managed to transform her smile. And this is, and it's always just take a look at their look, I mean, in their eyes, because you can really see the difference. These are the studio pictures, and just another case which I would have solved like in my conventional life with most probably 2 upper bicuspid extractions, and this is the result without extractions, and this is how her smile has changed. So just another example. And so this is what we want to have, a nice smile arc curvature, okay, a full smile, and a nice display of the teeth and the gum, okay. We call it vertical incisor display, or just nice display. I'm going to talk about it. So the Pitt's philosophy of orthodontic treatment is defined by extraordinary face aesthetics to have a superior aesthetic result. And I call it modern aesthetics-driven orthodontics. So this is what kind of fancy pictures we would love to take of our patients at the end of the treatment. All right, let's talk a little bit about Dr. David Sauer. David Sauer is an American orthodontist who introduced this new concept in orthodontics in the 1990s, which is called face-driven treatment planning based on aesthetic diagnosis. And Dr. Sauer introduced the terms of macroaesthetics, which would be the aesthetics of the face of the patient, the mini aesthetics, the aesthetics of the smile of the patient, and the microaesthetics, which would be the aesthetics of the teeth and the gum of the patient. Okay. So let's see the macroaesthetics or face aesthetics, the elements of it. So the profile, a very important part of it, the vertical proportions of the face, the lip fullness. The ladies are very keen for that. the chin projections. In Hungary, like 70% of the cases are class 2s, and obviously with retrograde chins many times. And one of my first questions to their patients that, okay, are you disturbed by your the backward position of your chin? Because it's important for them. And the nasal projections also part of it. And you can see other characteristics as well. Take a look at big ears and so on, but it's not that. It's just small percentage as the importance. The second one is the mini aesthetics or smile aesthetics of the patient. Here it comes, the incisor display or VID or vertical incisor display. Okay, because we need the right display again, the teeth and the gum. Okay, obviously it's around 2-3 millimeters, but it changes with for females. It changes with aging as well. We're going to talk about it. The transfer smile with the buccal corridors, because most of the orthodontists, they don't feel the buccal corridors of the patient aesthetically, obviously with the teeth and at the end of the treatment. The symmetry of the smile, the crowding or spaces. Obviously, mostly we have crowding, but sometimes we have spaces. And the smile arc, okay, which I'm going to talk a lot about the smile arc. So we need a nice curved smile arc. It's very important. And the vermilion display, the middle part of the upper lip. So these are the elements of the mini aesthetics, of the smile aesthetics. And the micro aesthetics, the aesthetics of the teeth, is the gingival shape and contour, which we can change with our laser. The triangular holes or pepper spots or black triangles, especially in adult female patients. Basically, I treat like 50% of my patients are adults. Partly because in Hungary, those who are 30, 40 years old or 50 or over, they didn't have a chance to have ortho treatment when they were children, or they didn't really have the right treatment. So they are coming, and adult female patients many times, especially if they are senior biotypes, we have to do interproximal reduction, which I will show you to correct the triangular holes, or ask for the help of our aesthetic dentist friends. And the shape of and the proportions of teeth is very important. Are very important. Obviously, we can check it, and we can do the right shape and proportions with digital smile design, or taking things from aesthetic dentistry, and we do that. All right. So what Dr. David Sauer said is that in contemporary orthodontics, diagnosis is based on the position of the upper incisors as it affects macroaesthetics, so the face aesthetics of the patient, and mini aesthetics, so the smile aesthetics of the patient. And Dr. Pitts joined already in the 90s the opinion of Dr. Sauer, which, yes, we can call it a new way of hard and soft tissue analysis. That in orthodontics, we used to base our diagnosis and treatment plan on the position of the lower incisors. Today, our diagnosis is based on the upper incisors, as their position mainly affects face aesthetics. Yes, you're not going to change the face aesthetics aspects of the patient by changing the position of the lower incisors. And honestly, actually, first of all, what we would like to do, and what I would like to do for you today, that I would like to show you how in my hands, on our hands, the Pitts protocol work, and why we use the protocols of Dr. Pitts, and why we teach them. But it's like in my traditional orthodontic life, from that I can tell you from my past, I can tell you that I never ever had stability when I put on 90 degrees the lower incisors. So it's strange for me. It didn't matter if it was I did extractions or I didn't do bicuspid extractions. So it's like there is no stability. I mean, it to me, in my hands, it never ever gave me stability. And now I'm in 27 years in this business, so I think I'm getting experienced. Okay, still, let's talk about aesthetics. So what we need to learn, and what you need to learn, is just you have to take a look at the face and the smile of the patient. And what I do, the first thing when I enter, or the patient enters, but usually the patient is already sitting in the chair or standing, I enter. And I check, when I say hi, how are you, how is your treatment going, what happened after we changed your last the arch trials last time, and so on. And so I'm communicating with the patient, and I see dynamically, I try to see his or her smile, the dynamics of his or the lips of the patient, everything, the smile arc, all this kind of stuff. And then, and many times I ask them just to stand up, and obviously I check the pictures, because we take pictures every time. And I want to check aesthetically everything before I get into the mouth of the patient, and I see, okay, that functionally where we are, and how the teeth are lined, and which direction we should go, and so on and so on. So from the front, so we have to check first the display zone. Okay, we call it display zone. This is where you see the teeth. Okay, and number two, in the display zone, we want to see the smile arc, nice curved smile arc. Okay, because why is that? Because most of the orthodontists, unfortunately, all over the world, they are still creating flat smile arcs, flat and flat and flat. Okay, which is not nice at all. This is what I'm talking about. It's on the right side, flat smile arc. Okay, and we need a nice consonant or curved smile arc, at the end of our treatment. I will show you how we do that. Okay, so again, let's get back to the display zone. So we check the smile arc. Okay, ideally the smile arc obviously has to be parallel the incisal edges and cups of the canines, and the occlusal surfaces of the premolars and the molars have to be parallel with the upper contour of the lower lip. This is there are other definitions for that, but this is the most classic definition. Okay, and it was already published in 2008 in an article that if we draw a perpendicular line to the incisal edges of the upper central incisors, then at the canines, the distance, the cusp of the canines, the distance should be 2.7 millimeters, and at the seventh mesial cusp 7.2 millimeters. And in this case, we can talk about an ideal. We can say that the smile arc is ideal. Okay, incisal display. This is also very important. So it's important the patient has to show his or her teeth. Okay, because if they are half covered with the lip, it's not good, and especially because with aging, it's the upper lip is coming down. So, and a little more 2 and 3 millimeter display is necessary for the females, and less display 1-2 millimeters for the male patients. Again, gingival display, ideally the height of the papillas is 2.1 millimeters, right here. Excellent inclination of the incisors. It's very, very important. Okay, a little bit later, I'm going to talk about it. This is one of the most important factors with our treatment. And also the excellent inclination of the cuspids. It's very important to have an ideal and beautiful smile, and the inclination of the buccal segments, because we do normally, not always, but we do non-extraction treatment. Otherwise, it would be difficult to have a 12-2 smile. But anyway, so it's like when we do expansion, then we have to upright those teeth, and this is why we have, more negative torque on the premolars, and especially on the molars. But I will talk about it. Buccal corridors are, making almost 60% of the smile, 11.6 millimeters. Still, I'm talking about the same article from 2008. And it's very important to feel the buccal corridors, because I have, as I have already told you, that orthodontists mostly, they don't feel the buccal corridors. And the last one is the midlines. So upper midline obviously has to be in the right place, and the lower midline should be on, but if you have a little bit of deviation, it's still fine if the occlusal, the situation of the occlusion on both sides is good. Okay, from the profile. What you need to look for from the profile, okay? Number one is the AP position, anterior posterior position of the upper incisors. I will talk about it, okay? Number two, which officially is number one, the axial inclination of the upper incisors. All over the world, what still today, unfortunately, what we can see is that with non-extraction treatment, the problem is the protrusion of the upper incisors, okay? Which is not good, because we need an aesthetic position of the upper central incisors because of various reasons. Shortly, I will talk about it. And this is very, very important. But still, what we see with other systems, especially with other systems, we have protrusion of the upper central incisors or the upper incisors, which going to ruin our aesthetic results. And so, yes, about the axial inclination of the upper central incisors. So our aim is that the lobular surface of the upper central incisors has to be perpendicular to the Frankfurt horizontal plane. This is our aim, and this is the lobular surface. Okay, it's not the long axis of the tooth. And with 8 degrees of inclination of the occlusal plane, it results in an ideal smile arc. So it's important to have that. And from the 45-degree view, we have to check that we need to have a smile arc in the buccal segments as well. It's also very, very important, because remember, we need the trap to smile. Okay, so our aim again is that the lobular surface of the upper central incisors is perpendicular to the Frankfurt horizontal plane, because this ensures the most aesthetic smile for the patient. Okay, reflecting the light and because of the position of the incisors of the central incisors. Proclined incisors negatively affect aesthetics. It's always a problem, even if we talk about a slight, couple of degrees or inside 5 degrees of proclination. What is the problem? The more proclined the upper incisors are, the less curved the smile arc will be, or in other words, the flatter the smile arc will be. Okay, so the more protrusion we have again, the flatter the smile arc will be. And the more protrusion we have from the frontal view, then the length of the crown of the incisors, especially the central ones, because they need to be dominant according to the aesthetic dentistry principles, it's going to get shorter and shorter and shorter. The more protruded the incisors are, the shorter the clinical crown appears. So this is why. Flat smile arc is not aesthetic again. Okay, we need a consonant curved smile arc. So the PIS diagnosis is based on the upper incisors to have superior aesthetic results, not on the lower incisors. Okay, I will show you cases. Unfortunately, we are already 40 minutes in our webinar. Unfortunately, we don't really have time to go into really a lot of details, but I will try to show you just the summaries of the cases. Hopefully, when we see each other in person, then we will talk about much more about the cases. So, 38 years old female patient. Remember, I have 50% adult cases, and you will see that my average cases are difficult cases in most of the ortho practice. That is fine. I really like challenges. Okay, so this is a pretty simple case, by the way. You can see that we have a deep bite. Okay, we have some gum recessions. Yes, sometimes they're already there at the beginning of the treatment, but if you correct everything and the teeth are in the bone or the tooth in the bone, it's not a problem, and we can have our periodontologist friends asked to help us at the end of the treatment, or even sometimes sooner. Anyway, we have a deep bite, and we have a class 2 tendency here, a little bit of class 2 on the right side, and more or less class 1 on the left side, or a little bit class 2 on the canines. But the problem is the deep bite. Okay, and I will just show you. Yes, the form of the teeth is not, the shape of the teeth is not was not ideal, and even you can see that I would like to see some more display on the gum. Okay, And her chief complaint wasn't, again, her AMB angle or SNB angle or SNA. Her chief complaint was that, I want to change my smile, doctor. You can see that we have, this is really narrow here. Okay, and one of the biggest mistakes what the usual orthodontist does in this type of cases, that they put even more incisively their traditionally positioned brackets, because they want to correct but with the intrusion of the lower incisors and the upper incisors, the deep bite. And this is not good, because I wanted to have a little bit more display on hers, so I stayed with my SAP smile protection bracket positioning. We call it SAP bracket positioning. So this is normal. This means normal torque. I will talk about torque selection. I will talk about torque selection later. And we started with class 2 box elastics, okay, to raise her bite, and then I did put on the lower sevens the disarticulation. Okay, these are the disarticulations. We put them on 2 teeth and right from bonding, and we change the position if it's necessary, obviously. And then I did my bracket positioning. We're going to talk about it. Yes, these are the disarticulations. And then, by using on the 7 the disarticulation, then with the short class 2, upper 4, lower 6, then obviously I can have the extrusive effect on my lower molars and premolars, because for the upper arch we bond for the smile arc, and the lower arch we bond according to the vertical bite dimension of the patient. So we will see that with the PITS active early protocols, we try to do everything at the same time in 3 dimensions, and to be as effective as we can. And you will see that especially with the PITS 21 and with the protocols, we can really reduce the treatment times. So, by the way, let's get back to this case. Then later we used a little bit longer with stainless steel wires posted in the upper arch, a little bit longer class 2 elastics, and then we changed the disarticulation from the lower 7s to the upper 4s. It's we kept moving forward the mandible a little bit, and then these are these were her finishing elastics. Okay, what you can see right here. And the treatment time was 17 months. It's not it wasn't a PITS 21 case. Okay, it was an H4 case, but this is the final result. Okay, she preferred to have no staircase effect between the centrals and laterals in the upper. I still recontoured a little bit her teeth, which we do. And so this is the final result: class 1 occlusion, upright incisors. You can see the X-rays, and this is how her display changed. You can see that we have a nice ideal position of the lobular surfaces of the upper central incisors, and these are the final smiling photos. Really nice smile arc, and you can see that there is a huge difference between the smiles. This is a 8-2 smile, and this is basically a 10-2 smile. Yes, this is just the before and after. All right, and so and you see, this is a life-changing experience for them, and I'm really truly very happy that I'm able to do this. So today, next to beauty or into beauty, to our patients, people want full lips, and they want a smile from ear to ear, a 12-2 smile, and most of the times, it's been years now, they come and see me that I want to have a nice shape of my teeth and I want to have a nice gum, doctor. They Google everything, and they're really prepared. And again, it's never their A and B angle. So let's see the PITS top 14 features for facial and spine aesthetics to look more useful and attractive, which are controlled by us, the orthodontists. Number 1 is the full dental mass. We need a smile full of teeth. In other words, we need a 12-2 smile, remember. David Sarver said, David Sarver said that, just get there, okay. Increasing dental mass over skeletal volume increases the perception of usefulness, which is really, really true. Number 2, proper inclination of incisors as cuspids. inclination is a major thing to aesthetics. In this case, this was her first finished ortho treatment. She didn't like, many times it happens that, yes, doctor, I'm happy. I remember it happened to me, when I did traditional orthodontics before 2004. So, yes, doctor, I'm very happy. Let's remove my braces. Then remove the braces, and then patient comes back or goes back a couple of days later. I don't know, doctor. It seems to me that it seems worse and worse to me. I can't just live with this. That my upper front teeth are sticking out a little bit, and I do say all the time, okay, so what, we are putting back the braces or liner treatment, up for uprighting teeth, or a lot of IPR or what? So we have to be careful with that, and remember, perpendicular, the labial surface has to be perpendicular to the front foot horizontal, or parallel with in natural head position, parallel with the vertical plane. So this is how Dr. Pitts finished her case, and her smile, was transformed tremendously. Number 3 is the smile arc curvature. It's really interesting that in 1958, it was already published in an article that the more curved the smile arc, the more useful is the look of the patient. It seems unfortunate. I always say this too, that orthodontists, they don't really read aesthetic dentistry articles or journals or books or whatever. So what we do, what you have already seen, is the Pitts SAP, or smile protection bracket positioning. So it means that from distal to mesial, we bond more and more, gingivally, the brackets. Okay, I'm going to talk about it today, later. And this is how we create a nice smile arc. So we do the smile arc control with bracket position. Yes, there are some exaggerated cases when we need to really, give more and more display. We can even put TEDs in the lower arch, and we can use elastics for that. But it's an advanced level, and we don't have time to talk about it today, unfortunately. So actually, that's my mouse, because I was treated by Dr. Pitts between September 2016 and July 2018, because we don't see every month each other. Okay, number 4 is the incisor and gingival display. Remember, we need nice display. Okay, this is not enough display. This is the perfect display with a very nice smile arc. I will show you this case later for you. Number 5, wide arch within in the buccal segments. So we need a 12-tooth smile. And Dr. Pitt says that arch development is the thing which he concentrates on for every case. We need to concentrate on for every case. The best way for arch development is, he thinks, and we think, that is passive subligation. Number 6 is the aesthetic and functional arch shape. And we use the Pitts broad arch wires, which are really broad. And you have to see that also it's not too wide in the canine area. This is really a wide arch form and the wide arch shape, and it's extremely important, the arch form you use. Why is that? And the Pitts broad is the only aesthetically optimized arch shape in the universe of orthodontics. So let me explain you an example. Like a couple of years ago, my students at the University of Sega, they showed me a case where in late mixed dentition, almost early permanent dentition, they used the Hyrax on a patient, and they did, in, I think it was 4 or 5 months. Anyway, it doesn't really matter. So they did an expansion on the upper arch, and to my surprise, it really looked like a Pitts broad arch form. And then they put the braces on, and they used some kind of conventional appliances. I'm sorry. And they ended up, because they used, a narrow U-form arch shape from a company, and they ended up with the same narrow arch form. So, and is it a surprise? Is it a surprise that you use some kind of arch form for 16 months, 18 months, for 2 years, I don't know, even for 12 months, and then the arch form of the patient will be like this? No, it's not a surprise. This is what you get. What you put in the mouth of your patients, that is what you get. Okay, so we use the pitch broad, which is really wide, but it's absolutely fine because we use light continuous forces on the teeth. This is very important, and I will show you that also to you. Why is that? Especially with the pitch anyway. Okay, number 7 is microaesthetics. So aesthetics of the teeth and the gum. We need rounded and softened incisal edges and manicured canines, and also manicured, premolars and sometimes molars. So we do tooth recontouring. We take a pair and we do recontour teeth when we have enough tooth material. So we don't want to have the pepper spots. We do interproximal reduction for that. So we want to have flattening contacts, long connectors in between the teeth. It's important the inclinations of the roots, the gingival shapes and contours. We can modify that with our laser if it's necessary. Also the proper zeniths and gingival heights. And we need the proper proportionality of the teeth. So it's coming from aesthetic dentistry. Okay, number 8 is the mini aesthetics. So the aesthetics, the smile aesthetics of the patient. Gingival smile line should match the incisal smile line. Okay, so it's the same that we need the harmony between the gum, the smile line of the gum or smile arc of the gum, and the smile arc of the teeth. Because we try to create harmony on the face, beauty and harmony together. Okay, number 9 is full upper lip. We need a full vermilion display, and we need that the nasolabial angle is approaching to 90 degrees. Sometimes it could be a little bit less. And it's determined by the anterior-posterior position of the maxillary incisors, right? What a surprise. So it's not determined by the lower incisors, but the upper incisors. Okay, number 10 is the aesthetic chin projection. It's an amazing case of Dr. Pitts. This young lady, before treatment, and how Dr. Pitts managed to have this gorgeous profile and chin, that he took out 2 lower bicuspids. He, did endmost reduction on the lower front teeth from canine to canine. Then, so he created the overjet. Then he put the herbst in the mouth of the patient. Then with the herbst, he moved forward the mandible. And he did it because he didn't like the profile of the patient, and the patient didn't like her profile as well. And take a look, this is amazing, really. Number 11 is the incisal plane cant, which is obvious. It has to be parallel to the interpupillary line. Number 12 is the dental midline has to be on. It has to be parallel to the midline of the face, and the upper midline should be right on the philtrum. Number 13 is restorative dentistry. So, considering the teeth and the gum as well. So, when we have good tooth material, okay, then we can recontour the teeth. When we don't have, good enough material, or big teeth enough, then we can use restorative dentistry, and we can use our laser to correct the gum, and it can really, really significantly improve the aesthetic result. Number 14, the last which is more and more popular also here in Europe and all over the world, is the soft facial tissue enhancement. So in other words, Botox. It's also getting very, very popular here in Europe as well. Okay. Another patient, 28 years old female patient. Again, this is a little bit of, it's an older case, but I just want to show you how we can change the smile of the patient and the look of the teeth, the shape of the teeth with recontouring, tooth recontouring. So it's, I don't want to talk too much about the case. It's like crowding, yes, upper and lower, class 2 tendency on both sides. You can see that, yes, it's a very narrow upper arch. And she wanted to avoid, because she was always told, I'm sorry, to have 4 bicuspid extractions, and she refused that all the time. And so we, that's her braces, with triangular elastics, we try to correct and control the vertical dimension between the upper canines, lower canines, and first bicuspids. We put the disarticulation on the lower 6, And these were her finishing elastics to suck the bite together. Total treatment time, that was 18 months, some years ago. This is the final result. I would like to see her wider today. But the thing is with the case that obviously, yeah, I could have had, I would do a laser, on 2-1 today. But, and we managed to correct the occlusion, obviously, and we managed to change the arch forms. The two, and with the 2C contouring from these T's, we managed to end up with this shape of the T's. Normally, tooth contouring, I do a base contouring when I bond the braces, and then I do usually twice during the treatment, and then at the end also after the removal. So it's the microaesthetics, which is very, very important. Okay. And again, I would like to see her wider today, but that was the case. Another case, 41 years old female patient. Just I'm gonna be faster now because I still have a lot of stuff to show you. Basically, she didn't have a big malocclusion, maybe a little bit of deep bite. His general dentist, aesthetic dentist, called me and asked me that, okay, why you wanna put braces on her? And I replied that no, she came to me and she told me, the doctor, after I got 40, I hit my wrinkles and I hit my forced smile. I'm just, my face started to age. And yeah, we put, you can see that this is SAP positioning. I'm sorry, I should come, yes. So SAP positioning, you can see that it's very close to the gum, but if you remove the flash, then it's not a problem at all for the hygiene of the patient, because everybody's like afraid of this. Oh my God, what's going to happen? No, if the patient has a good oral hygiene, and if you teach and explain well how the patient needs to brush her or his teeth, then you can be sure that it's not a problem. I know with teenagers we have some issues. Yes, that's right. But not with adults. Anyway, class 2 box elastics. These were her finishing elastics. We were ready after a year. It took me a couple of months. I convinced her to do interproximal reduction because, here, this is, this is not good. And we did interproximal reduction, so the total treatment time was 17 months, and this is the final result. I did recontour her teeth, and you can see that her facial balance harmony has completely changed, because with the light continuous forces, with the peace protocols, we really have a new balance, muscular balance also on the face. These are just the before afters, and you can see that we changed a little bit of the occlusion and just slicings, slight touches with tooth recontouring, and you can see how we managed to transform her smile. Just like that. Okay, and you can see that nice smile arc, and so it's, I think the pictures speak for themselves. All right, so once again, the PIT's main aesthetic parameters is the number 1, full dental mass. Number 2, proper inclination of teeth. Number 3, smile arc curvature. Number 4, proper display of the incisors and the gum. Number 5, the full upper lip and the right position of the chin. Number 6, the wide aesthetic arch form. And number 7, that we have to work on the microaesthetics. In most of the cases, we can work on the microaesthetics. So we call it a wow smile, okay, because it has to look so good that when other people see the patients after the braces are removed, they say, wow, what a gorgeous smile. So these are the elements of a wow smile, and for, as I have already mentioned it to you, and probably you face with that more and more in your everyday life, aesthetics is not the big thing for the patient, it's the only thing for the patients. All right, and we don't just need good aesthetics, we need wow-worthy aesthetics. And luckily, we have the technology and the case management to have these results. And this is one of my favorites from Mark Ackerman. He's, unfortunately, he passed away. He was, I think, at my age. Orthodontics is the art of the possible, not the science of the improbable. Okay, so remember that. So Dr. Pitt's treatment philosophy is the result of his 51 years experience in orthodontics, more than 50 years, and still changing today. So he keeps, changing the protocols every time I see him, and he's fantastic. So in summary, again, we have an aesthetic-based diagnosis and treatment planning. What we want to achieve is an extraordinary aesthetic result, considering the teeth of the patient, the smile of the patient, and the face of the patient. And obviously, we also want to have healthy occlusion, periodontium, and temporomandibular joints. So it's still the same, but we, take a look from another aspect. We start there. So in summary, aesthetics means everything to the patients. Don't adversely affect aesthetics to create a good bite. We shouldn't do that. Our patients, they want a full smile and protrusive lips. We have to protect and or enhance the facial and smile aesthetics we can control. And when necessary, we have to use restorative dentistry. And this is also one of my favorites from Dr. Sarver, is that don't make the kid ugly to get a good bite. All right. So the next topic should be, or would be, diagnostics. Actually, part of the diagnostics, which is the god of the diagnostics in orthodontics till today, is cephalometric analysis. It's funny. Like a year and a half ago, I went to a congress where there were different type of not just Pete's speakers, but other speakers as well. And it was still very interesting for me that they kept talking about cephalometrics for, I don't know, for half of their lectures, or I don't know, maybe 30% of their lectures. So it's strange because yes, cephalometrics is a part of the diagnostics in orthodontics, but it's just one part of it, and it's not the from the aesthetics point of view, it's not the most important. All right. So what we check in cephalometrics aesthetically. So number one, remember that the labial surface of the upper central incisor has to be perpendicular to the Frankfurt horizontal plane. This is number one. Number two is that the labial surface of the upper central incisor has to be sagittally at the same height with the anterior nasal spine, or it could be a little bit more forward. And number three is that the incisal edge of the upper central incisor has to be 2-3, or it could be 3-4 millimeters under the stomium, okay, which gives us the display, or the necessary display for our patient. Okay, so from the aesthetics point of view, we check the upper incisor. And again, cephalometrics, yes, it's important, but this is what we check aesthetically on the cephs. Okay, that's it about diagnostics of cephalometrics. Another case, 38 years old female patient, and just I'm showing this for aesthetics to you. It doesn't look a difficult case, but it's not that easy because of the display. So she had ortho treatment when she was a child, and they took out 2 upper bicuspids, and she had a class 3 tendency and upper and lower crowding, and as you can see. And she didn't care about her class 3 tendency. She cared about her, crowded teeth and usual, sentence, "I hit my smile, doctor." That's before, and we don't have enough display. You see, that's a huge weapon in our hands, that with the DSD, digital smile design softwares, or yes, actually, you can create a smile simulation in minutes. And because they cannot imagine, they are not able simply to imagine how their smile would look like. And we can talk for hours how, in words, that how we could change the smile of our patients. You show them picture, and then in less than a second they get it. Okay. We flip the, this is how we change the torque. The standard torque on the upper incisors is positive, and then we flip them, invert them in 180 degrees. So we invert the brackets, and then it's gonna be negative crown torque. I'm talking about crown torque all the time. I'm gonna talk about torque. So negative torque, we wanted to avoid protrusion, obviously, because we had some crowding in the upper, and we started it through the by class 3 elastics. You see, short class 3 elastics, upper palatal buttons of the upper fives and the lower canines. We put this articulation on the upper first molars, and because this is, we don't have unfortunately time to talk about it, but this is how we can have a clockwise rotation on the maxilla. So in other words, to give more display, to move downward the upper frontis and give more display for the upper frontis and to the spine of the patient. Later we continued with class 3 elastics right here, okay, and these were her finishing elastics, okay, and we did some DSD on her. And you can see that I changed her. She let me. Normally, I'll just get back here. So normally I put only aesthetic brackets from canine to canine in the upper, and but you know, it's like we started like, I don't know how. I'm sorry, I need some energy. Okay, that's fine now. So so we started like, I think around, I started around 500 cases last year, and you know how many aesthetic brackets are bonded? This zero, none. Because it's just, everything is about communication. As soon as they understand that our torque control is so much better, and torsional control in general, with the metal brackets, then they realize that they also by using the metal braces, we can be much more effective on their aesthetic result. You know, they do everything for aesthetics or to avoid orthodontic surgery, and so that's the secret. And actually, it's not a secret. You just have to do the communication. Everything is about communication. So I, again, in the last year, in the last 12 months, the number of aesthetic braces on the upper front teeth which I bonded is 0. All right, so DSD here, and yes, you can see the brackets are flipped. I mean the doctors who have experience total treatment time was 16 months, and nice arch form. You can see that this is the piece broad. Actually, this is really wide, and we changed the display. This is not, you know, she can smile bigger actually, and that's how we managed to change her smile. You will see that, okay. And this is a forced smile, but still great. And this is the smile before, the smile simulation. And I think the final result is even better than the smile simulation. All right, okay. And these are her studio photos. Remember that she has they had taken out 2 upper bicuspids for her, and still it's like with tentis, it could be even a tattoo smile. So this is, you know, it's again a life-changing experience. All right, let's talk about orthoclassic, and let's talk about a little bit about our appliance. Okay, so it's like, now we went through the aesthetic part, and I know for you orthodontists, everybody's fancy for biomechanics and all this kind of stuff, but you have to understand that we can arrive to the most perfect aesthetic result by using the right biomechanics. So, orthoclassic is situated in McMinnville in Oregon in the United States of America. One of the great advantages of that, let's get back for a second, is that, like, you know, many companies, they you know, that one thing is they make in Asia, the other thing is in, you know, in South America, the third part there. So basically we have one facility, and almost everything is done there. Okay, we started with the H4 system in 2012, and it was a huge improvement already. It was a huge difference, and with the design, with everything. and mostly, yes, we have a buckle tube. Obviously, what you use, this is the H4 bracket system, and yes. So what is the important thing about that is that we had what we had never seen before, extremely precise control with an 022, 026 slot size. Okay, let's talk about the second, about this 022, 026 slot size, because this 022, 026 slot size gives us an excellent torque and rotational control. Because a precise bracket wire coupling gives you improved rotational control and more accurate torque expression. So it's torque and rotation, because rotational control was considered as one of the weaknesses of the passive self-ligating systems. And this is why they created active brackets. And torque control. Remember, this is with non-extraction therapy. That was always a problem, that the protrusion of the especially the upper incisors. Okay, so you could say that, oh yes, but everyone has an 022, 026 slot actually at that time, but there were independent various studies. They discovered that the almost all of the companies who said that our bracket is, or their bracket is 022, 026, then it was 022, 028, okay, because of the tolerances, of the manufacturing tolerances. And just take a look how big is the change of play we used to use, and most of the orthodontists still use rectangular arch wires in the slot of the brackets, obviously. So the yellow is the play. So in an 022, 028 bracket in the slot, this is how big the play is with the 19 by 25 arch wire. This is with the 022, 027 wire slot. I'm sorry, with the same wire, and this is with the 022, 026. It's a huge difference. So tolerances are very, very important, because obviously with tighter tolerances we ensure predictable finishes. And the H4 already coat couple up to 57% sooner, providing really exceptional finishes much faster. Because by using a 19 by 25 wire, we had 6 degrees play, and with the 022, 026, really 022, 026 bracket slot size, and 14 degrees is the play with the normal usual slot, which is a huge difference. It's like you buy in male language, let's say, you buy a car with 150 horsepower or maximum 200, or you buy a car with 500 HP. It's a huge difference. And with the PITS 21, actually, what Dr. Pitts said when he created this his PITS 21 system, that it's time for a fresh look at what we have accepted in performance from our fixed appliances. Because the big problem was also my problem, which I never took a look of it, is like I bought, I checked the official values of the appliances I bought throughout my career, but I never checked that I really got the same result what I was told that I should have by buying the appliance. And and when you buy a Ferrari or Lamborghini, you expect that they're gonna perform as a Ferrari, Lamborghini. Or for ladies, if you go to a Chanel store, which is fantastic, and you buy a bag, and for price of a Chanel bag or Chanel, anything, clothes, whatever, or jewelry, and then you expect that you get that quality. But also, including myself, I never checked that, and usually what I had, it was much poorer quality what I paid for. And I was struggling with my torque, I was struggling with protrusion, I was struggling with a lot of things, and still, believe me, this is the problem with most of the braces on the market. And so Dr. Pitts created in 2007. It came to the market, the Pitts 21, which has a progressive slot with a progressive slot. The reason for the progressive slot was that he wanted to have more control, and we definitely have much more control with the Pitts 21. Progressive slot means that we have the slot size on the anterior teeth from canine to canine is 021, 021. On the bicuspids, on the premolars, it's 021, 023. So the vertical dimension of slot is unchanged, the horizontal dimension of the slot is changed. So we have 021, 021 anteriors, 021, 023 bicuspids, and 021, 024 molars. Okay, so basically the vertical slot size is the same, and the horizontal slot size is changing. And the reason for that is that because we want to have more control, torque control on the anterior teeth, and more sliding mechanics for expansion on the bicuspids and the molars. And we use so-called square wire finishing, so we use square arch wires, and with the square, arch wires, we are even more gentle with, with much less torsional load we give on to the teeth to move them. So we have much better three-dimensional control, sooner, simpler, and with lighter forces. And so we have, right here, gentle forces, control earlier treatment, control during space closure, early torque control, early and easy rotational control, early tip control, more predictable outcomes, square wire finishing, and we are at the full-size night-type wire by the third wire, and we use fewer arch wires and less force. We have a metal mode injected progressive slot. We have an improved base, integrated smaller hook, real timing, solid bracket body, and tougher slide. Slide was also, a tough slide. This is very important. Okay, as far as the torque values are concerned, Dr. Pitts, after the H4, he hasn't changed the torque on the upper centrals, on the upper bicuspids, and on the lower upper incisors. Upper central incisors, upper bicuspids, lower incisors, and the lower bicuspids. Okay, what he has changed is from 8 degrees to 6 degrees the upper laterals. So the H4 is 8 degrees and the 6 the PIS21. From 7 to 9 degrees the canines, both the upper and lower. This is what torque-wise. This is what he's changed. And we have the tubes with really high torque values. You see -22 on the 6 and on the 7s or 6 and 7s -27. I use just a little bit of background tip. I use per -27 both on the upper 6 and 7s, and it's -22 on the lower. Remember that as by doing having expansion, we need to upright those teeth. Okay, we need oral lingual crown torque. And so the tip control is even better. You see here on the left side, this is the 021 slot with a 20 by 20 square arch wire. With 1 degree of play and traditional passive flagating bracket with an 022 OT8 slot. In reality, with a 19 by 25 arch wire, has 2 degrees of play, and the rotational control is the same. So it's even better on the front teeth, and this is the biggest thing what we have, that the torque control with the PIS21 with the 20 by 20 arch wire, which we very soon get there. I will show you a slide for that. We have 4 degrees of play only, and 11 degrees of play with the 19 by 25 with the general usual slot sizes 022, 028, and it's a huge difference. Okay, so this is actually how. No, okay, I just need to click right here. So this is, let me show you how we open the brackets, okay, and open and closing the doors. This is the uppers, and you see here that by opening the brackets, just the uppers are flipped. So just Dr. Pitts just holding in his right hand the opening instrument, okay, and with one of his forefinger on his left hand, he pushes a little bit the opening plier, and this is how he opens the doors, okay. And you have to hear double click. It's very important. Double click. This is when the brackets are opened, and double click when you close them. You can close them with a finger, okay, your fingernails, very easy, just like that, okay. And yes, are inverted or flip the upper centrals and laterals, and you can close them with a Vanguard plier also, just like that, okay. And the important thing is to remember, let me show you and you can close them with a Vanguard plier as well, just like that, okay. Be careful, the ones who have just started with our brackets, just don't remove the brackets, okay. Don't use any rotational force, just vertical force, okay. And with the lower is opening, remember again that you see right hand is holding the opening instrument, and with the left hand, just one finger just pushes the door, okay, into the opening direction. Because if you just with one hand try to pull the instrument, then you can really remove the door if it's too big force. And first of all, it's can be painful for the patient, okay. And it's the same to close it with the finger, okay. And now we have this new, because you can use a ligature cutter to when there is some calculus, and sometimes it's difficult to, especially with bed oral hygiene, to open the brackets. But this is the new opening instrument, which I just received like this week actually. So we didn't have the time, unfortunately, to take a video for you, to make a video for you. But this is the opening instrument for the H4 and PIS-21 brackets, because the doors are the same. How you can differentiate the doors or the brackets? So on the PIS-21 right side is the H4. Obviously, this is an H and a 4. If you haven't realized that, okay, on the logo, the bracket. So the hook is definitely bigger on the H4 bracket and smaller on the PIS-21 bracket, okay. And you can even with the Vanguard, bend the hook, which was not possible with the H4. And you have a cavity, a round cavity. You don't have any cavity on the door of the H4 bracket, and you have a cavity on the door of the PIS-21. Because our philosophy is Dr. Pitz's philosophy that if you take a look in the mouth of the patient, you have to see what kind of braces the patient has in his or her mouth, and so what kind of brackets, and how the brackets were positioned, how the torque was chosen, okay. And with bracket flipping, the bracket flipping, it introduces torsion. It's a very, very simple approach to get predictable results. Very really just like that with the 20x20 wires. And because we have active torsion, which is really very present in a common practice, I mean, with others in other systems, and incremental increases in the arch wire size are not effective at hitting the target. I will show you why. Okay, let's just get so because we lost some time here. So we have just an advantage from the first dimensional arch wire, and it's much better than the rectangular slots, the square slots. And again, it's we have 4 degrees of play with a 20x20 on the front teeth with the PIS-21, and with the 80x25 arch wire, we have almost 14 degrees of play, which is a lot, and it doesn't give you any control. I'm talking with my experience, because I was really starting years ago. So better slot geometry improves the performance of the appliance, and this is 250% better, which is a huge improvement. So progressive slot. So why we have the difference between the front, the slot size on the front brackets from canine to canine, and on the bicuspids and on the molars? Because on the front teeth we need tighter fit for the precision, especially for the torque control, and we need on the premolars and the bicuspids, I'm sorry, and the molars, we need looser fit for the sliding mechanics for expansion, okay? Because obviously how we, we have crowding mostly, okay? How we can solve the crowding, we need to make expansion, okay? So this is how we create the space to apply the T's. And we can do interproximal action also. We use always low torque, obviously. I will talk about the torque selection. So every piece of the puzzle you have to put in place, and then you really have the most dangerous weapon in a positive way in the history of orthodontics, what as far as the PITS 21 system is concerned. Again, we have torsional contour in the first dimensional archfire, which is 18 by 18, and we are on the target for the first time. So we really have true control in 3 dimension. I will show you. Okay, and yes, rotational control is better, much better, and it's also 250% better. Anterior rotational control, posterior rotational control. I'm just getting through faster these slides. Better at the start and then rectangular finishes. It's really like that. Okay, so we really realize that the traditional archway progressions are not effective. Okay, I did the same, many years ago. Started with the round wire 01, 013, 014, 016, 018 even, then 40 by 25, then 18 by 25, then 19 by 25, and even lots of inventory. We have slow progressions and even questionable torsional control at the end when we had the 90 by 25 wire in the slot. And with the PITS 21 archway progression, active early archway progression of Dr. Pitts, we use alloy technology to deliver forces, and we use very few wire profile changes because we start with the round wire, which is 014 if we have to. Then we use the 18 by 18 wires, then the 20 by 20, and that's it with the night time. And we really have total 3D control early with a simple archwire progression. And we apply 30 to 40% of the torsional load of the rectangular wire. So it's much, it's 60, 70% less force what we use on the T's, and still we are much more effective. Okay, it's like kind of paradigm shift, but you have to understand that because we orthodontists, we are socialized to, if a tooth doesn't want to move, then we put more force in it. Then we take our boxing gloves, then we start to hit the tooth, even if it's necessary. Then we use our legs to kick it. You know what I mean. And then you have to stay light. Okay, light continuous forces. Remember, this is the key. Okay, we don't need to force the issue. It's like you are touching the love of your life, and then you are trying to be as gentle as you can. Yeah, right. This is how we do that. So you have to do the same thing to your patients. And by the way, I for expansion, it's I'm talking about my hands, okay, but I haven't used Hyris or any robot powder expander since 2004, since I changed to passive self-ligation, because in my hands it's simply not necessary. And believe me, patients are really happy to avoid that. Not just orthodontic surgery. I have a lot of cases who are, who officially or originally they got the opinion that they need orthodontic surgery. Anyway, so simple archway progression with total 3D control early in the treatment, and much less, 30 to 40% of the torsion load less of the rectangular archwires. Okay, I would like to, good. So we have a reduced inventory, aesthetic optimized piece broad arch form. We have a simplified active early archwire progression, and we have a 4-wire progression potential. And again, we use the Pitts broad arch form. This is a single aesthetic optimized arch form in the universe of orthodontics. It's very important. Remember, the arch form you use, that's the end what you have with the form of the dental arches. So we have much more control, So we have managed to reduce definitely the treatment time. Why is that? Let's take a look at the traditional archfire sequence, okay? Rectangular archfire treatment, and it's said O2 to O2 6, but in reality it's O2 to O2 8 slot. So basically, we need almost a year to get questionable control, because we used to see our patients every 10 weeks and also ourselves. Then it became 8 weeks. Today with PIS21, I see my patients every 4 weeks. In the finishing, many times I see them every 3 weeks. And the average treatment time is around 14, 16 months. Yeah, I mean, maybe 14, 18, because I have a lot of complicated cases. Anyway, so almost a year, 50 weeks, or let's say even 10 months or 11 months. Then it's 19 by 25 stainless steel and 11 degrees of play as far as the torque is concerned. So it's way too much. And with the PIS21 archfire sequence, though we did this chart when we saw our patients every 6 weeks. So 014, 18 by 18 night tie, 20 by 20 night tie, then 20 by 20 beta titanium or 19 by 19 stainless steel. Then after basically 3 months to see the patients every 3 weeks, we have, but sometimes it's only 2 months. So basically we had a little bit more than 4 degrees of play. So we have total control of torque. And the problem with torque is that I always try to emphasize this, that it's like the usual orthodontist, I would say, that has a lazy attitude. In Spanish, they say mañana. So in other words, tomorrow, okay, we have time, so we do that. Okay, no worries. If the patient comes back next time, and then we do that. Not today. Too many patients. I'm too tired, and so on. It's like I have been in this boot, so I know what I'm talking about. But the problem is that you can be the most effective if you do what you have to do when the patient is there. Okay, and don't waste your time, and don't waste, first of all, don't waste the time of the patient, because the faster you are, the happier the patients are, obviously. And really, it's very important to do all your things when you need to do them, and then you need to make those changes to arrive to the right result. Okay, so again, it's very fast control we have. And what is important with this mañana attitude, that it's protrusion happens, it's like you do something, you do the activation, you insert the archfire, patient goes away, and even if you see the patient every 4 weeks, then what happens in 4 weeks? Bam, this protrusion. And then it takes 4, 5, 6, or even more months to get back to upright those teeth, to get back to the original position, which is obviously a waste of time, and it's a luxury now. And so our attitude is with the PIS protocols is that we want to control the torque as soon as possible, as effectively as possible. And with this, we really, save a lot of time. So we have superior performance in weeks and not in months. Remember that. So we have 3D control in all dimensions sooner. Okay. Hopefully soon I will see you soon, and I will have more time to talk about it. Okay. And the Clear 21 is coming. It's the aesthetic version of the PIS21, obviously. It's here, and it's going to have the same powerful benefits as the PIS21. Metal brackets, and this is a new technology what you can apply. It's called quick turn. So it's basically you just turn with 90 degrees the opening instrument, and then you open the bracket. So the PIS21 basically is finally, in my opinion, the Ferrari of orthodontics, and you just need to learn how you need to drive it, okay? Because it's very important that even the faster car you have, the better driver you have to be, and you have to practice, and you have to learn how you can use that. So you need to use the right protocols. By the way, let me just go back here for a second. So This name here is Albert Ruiz Vela. He is considered to be the best orthodontic engineer in the field of passive cephalogating braces in the universe, and in my opinion, Dr. Pitts and many others share that is the best orthodontist in the universe. So the Pitts 21 is the product of the best orthodontist in the world and the best orthodontic engineer in the world. Okay, Albert is truly fantastic. So let's not forget that. Thank you, Albert. Okay, I just wanted to show you this, so I went back a little bit with my slides. So I hope you can understand everything, and I'm trying to be not that fast, but time is running up. Okay. 32 years old female patient, Pitts 21 case. Remember, I told you we have a lot of class 2 cases in Hungary. You can see obviously that not from here, but already that we have a protrusion, and we have a full step class 2 on the right side, and we have a half step class 2 on the canines on the left side. We have protruded incisors. These are the X-rays. Lower wisdoms are already taken out. Uppers not yet. And this is why the patient came to my office, and she said that I was not the first orthodontist she saw, and she hates her protrusion, but everybody wanted to take out 2 or 4 bicuspids for her, but she doesn't want to have that. And she was one of my first Pitts 21 cases. We don't have the right display, you see. This is not a good display, okay, here, when the patient is smiling. And it's like, there is no way I would ruin this gorgeous profile, okay? No way for that. And by extracting 2 upper bicuspids. Okay, I flipped the brackets because I really wanted to see the control of the Pitts 21. So I flipped the upper brackets, upper incisor brackets, and we started through the bite elastics. In class 2 cases, I use volatile buttons on the upper 4s, and we put the disarticulation upper 6 because, again, if you want to have a clockwise rotation of the maxilla, then unfortunately, don't have more time to explain to you, but this is how we do that. Okay. Otherwise, when we have an open bite case, we put on the upper molars because we can have better intrusion, so to close the bite down. So that is the other scenario when we put the disarticulation on the upper 6. Okay, and we started with through the bite class 2 elastics between the palatal buttons on the upper 4s and the lower 6. What we do is that through the bite elastics, we have expansion in the upper arch because, remember, our shoe has to be big enough that the leg can get there, and the feet or the foot, the mandible, in other words, can go forward. And you see that also the curve of speed is always a problem with class 2. So I really position very incisally, sometimes even much more incisally, my lower front brackets, and really gingivally my lateral segment brackets on the premolars and the molars. And obviously, when it's an adult patient, it's easy because of the crown lengths. Okay, and later when the upper arch was or is wide enough in general, then we go vestibularly with the short class 2 elastics, upper 4 or 6. Then we have the Panoripo appointment. Panoripo adjust case management appointment, when we reposition brackets when it's necessary for various reasons. I will show you later in a couple of slides why is that. Then we change the disarticulation to the upper 4, which is a kind of class 2 disarticulation. I call it because there is a ramp in it which has a kind of Herbst effect, so that as the patient closes, it pushes forward the mandible. So it definitely helps with the elastics to correct the class 2. Remember, it was full step on the right side, now it's just half step. And remember, you can see that she's a thin biotype. Okay, it's never easy, the thin biotype. But don't worry that you can see the roots. Yes, she's a thin biotype, so the roots are in the bone. Finishing elastics class 2, total treatment time was 22 months because she wasn't the best with her elastics. And this is the final result, perfect occlusion. We managed to upright the incisors. She didn't allow me to do interproximal reduction and tooth recontouring, so you can see how we changed the form of the upper arch. And throughout the treatment, just like that, then we changed to the class 2 disarticulation on the premolars, and this is how we finished there. And you can see there's a nice broad arch form. I always use fixed retainers. This is these are the x-rays after. You always have some protrusion in the lower, but you can see because of the class 2 elastics, it's obvious. And then nicely upright upper incisors, and you see that she has a nice display. Look how her smile has changed. It's really a huge difference. These are the before and after pictures. Okay, good. So let's talk about the SAP's bracket positioning or smile arch protection bracket positioning. I'm sorry. Okay, and so this is on the right side. You can see the traditional positioning. Obviously, incisal brackets positioned incisally, and the SAP positioning is on the left side, which means that we are going more and more from distal to mesial. We are going more and more gingival to have a curved, nice smile arc. Okay, just like that. So higher on the canines, higher on the laterals, even higher. From the first molars, starting from the first molars, we are going higher and higher to have the nice curved smile arc. Okay, so finally we have a reason to place brackets. Duncan, yes, said that we have better aesthetics and better performance of the appliance and better consistency. So in the SAP bracket placement, the white tissue increases towards the anterior teeth. We call it bracket progression. And basically, it's like you see more and more white tissue under the brackets, the upper brackets, and when it's combined with the 8-degree cant of the occlusal plane, then it results in an aesthetic smile arc. And it continues in an NHP more white tissue as we see as we move anteriorly, just like that. Okay, so this is what you see. You see more and more white tissue under the brackets. Okay, and we basically check the contact points and the mesial-distal contact line of the teeth, not the marginal ridges. Okay, when we position the brackets. Unfortunately, again, I don't have enough time to talk about it. So the lower arch must be over-leveled to allow greater upper incisor display without increasing the overbite. Because what happens by positioning so gingivally the upper brackets, and yes, it depends also on cases how high we go or we don't go. But anyway, again, we don't have time for that today. But so the important thing is that obviously the overbite will get bigger, okay, because of the SAP positioning. And because of that, we have to overlevel the lower arch, which means that we have to, we don't want to increase the overbite, so we have to have some intrusion on the low front teeth relatively to the upper extrusion. Especially even when we want to allow a greater incisor display, because we need to give more display, so we need to move downwards the upper teeth. Okay, but in any case in general. So the pitch smile protection bracket bonding, upper arch is bonded to create a smile arc. This is very important. Don't forget that. And the lower arch is bonded according to the vertical bidimension. So basically, it doesn't really matter what kind of malocclusion and vertical bidimension the patient has. The upper arch is bonded to create the smile arc. Okay, always. So upper arch for the smile arc, lower arch according to the vertical bidimension. In deep bite cases, the premolars and molars, we position them more gingivally, and the canines and the incisors more incisally. And it's an open bite. It's the opposite. It's the basic rule of thumb for bracket positioning. premolars and molars, we position them more occlusally, as normally we do with the open bite cases, and the canines and incisors more gingivally. Okay. We use the minimum amount of bonding material. If there is flesh, it's bad for the oral hygiene and could be less precise. So we always remove the flesh, and especially we remove the flesh between the gingival side of the bracket pad in the upper arch. So we don't want to see any flesh between gingivally from the bracket between the gum and the bracket. Okay, it's very, very important. So the upper incisors brackets are positioned gingivally from the FA point, okay? And the archwire plane is parallel to the upper lip, and the teeth are aligned. I'm not talking about crowded teeth in the beginning of the treatment. And the incisal occlusal edge of the teeth is parallel to the lower lip. Okay, so this is how we do that. All right. Okay, so the smile protection bracket positioning, SAP positioning, why is it better? Because it gives us superior aesthetic results, okay? It gives us a much better control of the axial inclination on the front teeth. It lines up the contact points, and it activates torsion very, very early. And it improves the performance of the pliance. Okay, and patients, really like it because braces are less visible. Remember, I exclusively bond only metal braces because we always manage the patients to convince not to have the aesthetic brackets. Okay, and this is me in 2008. Would you believe that? Oh my gosh, 2008. That's a case. In 2009, it's like when you want to go up to the Mount Everest to climb on it, okay, you're not going to start there, okay, because you have to prepare yourself. So you're not gonna go to 8,848 meters. You start with 500 meters, then 1,000, then 1,500, and so on. So you see what I mean, and you just can't, and it's also very strange for your eyes, and it's very strange for your hands, for everything. So you just try to climb higher and higher. And this is 2010, 2011, and 2012, and 2013, and I'm still, for example, here I didn't go high enough. Okay. Practice makes the master. Let's not forget that, never. So in 2014 I arrived here. Okay, you have already seen the case. So it's like it took time. It took 6 years for me, 5-6 years. When Tom said me, yes, Peter, this is really good now. Okay, we use a vertical SAP positioner. Okay, you can get that from Orthoclassic with different values. Okay, now we have 3 types of the positioner. Okay. And that's it. Okay. I wish we had more time for more details for the values, but I'm sorry that we don't have for that. But basically, just start. You can find a Tom and Tom chart in the PEACE protocols, and just start to use it, start to go higher a little bit, and then higher again. Okay. So the 2-year-old female patient with crowding and open bite, also seam biotype, and she hadn't had braces because she was always told they needed to take out 4 bicuspids, and she was told to have orthodontic surgery as well. She was not bothered by her chin, but anyway, it's much easier to correct the bite than have a chin genioplasty surgery than to have a full orthodontic surgery. Okay, and yes, so we started with her. When we don't have, I will show you another case where I show you that we don't engage the ectopic teeth lingually or buccally. So we put a coil spring there to create a space, and we started with class 3 direction V elastics on her to start to close the bite down. And if it's open bite case, then we put this articulation on the upper first molars. We use this so-called rainbow elastic to close the bite down. And this is how initial 6 months, 10 months, and 17 months she had also speech therapy because of the tongue issues, upper arch development in 17 months, and the lower arch development 6 months, 10 months, 17 months. It took a while, and then the finishing elastics, and the total healing time was 19 months, and this is the final result. I did recounter her teeth, and we did interproximal reduction, and this is a nice display and a nice smile arc. These are the before afters. Again, she's a SIM biotype, but she's stable and fine. I finished her a couple of years ago, and I just saw her like last month. Okay, no root resorption, and she was really very happy. For her, it's a life-changing experience. These are the studio photos. Okay, so one of Tom's favorites, phrases is the begin with the end in mind, which means that finishing starts at the beginning of the treatment, and we go from point A to point B with orthodontic treatment, and but obviously we have to use the right protocols to arrive from point A to point B. I do tell to my patients, and actually to my colleagues as well, that orthodontics is like sailing against the wind. Okay, it's like when you have front wind and then you want to go that direction, the wind comes from that direction, then we go a little bit left and then a little bit right, and we are just keep getting back to our the direction of our point B, and never forget that, and remember, don't use the mañana habit. Just do everything at the certain time what you have to do, okay, to go forward. So torque control, remember, it's very, very important. So let's talk about how we choose the torque. P21 torque values, we use a simplified torque selection, and the normal torque is plus 12 on the upper centrals, plus 6 on the upper laterals, plus 9 on the upper canines, and minus 11 on the upper premolars. So what we do, that we invert with 180 degrees. So we flip the brackets. We call it flipping on the incisors and flocking from canine to canine. So it's going to be minus. We use the same brackets. We just invert them. Minus 5 on the centrals, minus 6 on the laterals, minus 9 on the canines. And in the lower arch, so the standard torque is minus 6, okay, on the lower incisors. Standard torque is negative. I'm talking about crown torque again. Remember that. Plus 9 as in the upper on the canines. Minus 12 and minus 17. We need more on the premolars, lower. And if we flip, when we flip the lower incisor brackets, then it's minus 6. Actually, from minus 6 it will be plus 6. And on both the laterals and the centrals. Okay, so this is how simply we do that, and it's extremely rare that you can flip the lower canine bracket to have, when it's really, baccally inclined the crown, and then you can have negative torque minus 9. Or it's really, the root is in lingual position, then you want to upright the root. Okay, so this is how we choose a torque. And on the upper front teeth, torque depends on the external inclination we would like to achieve. If you don't want protrusion, we use low torque brackets, flip vertically with under the 80 degrees. From 2 to 2, it's called flipping, and from 3 to 3, it's called flocking. We do vertical flipping on the lower incisors, so we have in this case a high torque, because remember, from minus 6 we do plus 6. Is used in class 3 cases, with upper low torque. So we want to avoid the side effect of protrusive on the upper incisors and the protrusive on the lower incisors side effect of the class 3 elastics, or if you use TEDs or whatever. So we do flipping on the lower incisors in class 3 cases, or if there are spaces. So in other words, proclination necessary when we close the spaces, not to have the retrusion on the crowns of the lower incisors. In acceleration cases or spaces, we use the maximum high or highest torque. On the upper incisors and canines, we use the normal positive value torque, and on the lower incisors, we do flipping, so we use high torque. Okay, so this is the basic rules for choosing the torque. So let's see normal vertical bracket positioning, upper canine from up on the upper from canine to canine. So +9 on the canines, you see how the bracket will be seated on the tooth, +12 on the centrals, and +6 on the laterals. And what happens? This is the how the slots will be on the incisors, and then you close the brackets just like that. The brackets are in a standard normal torque position. They open incisally or occlusally. Okay. And when we use flipping, okay, and then it's +9 on the canines because we don't flip them. We flip only the incisors, the centrals and laterals. It's going to be -12 and -6. And now you can see the brackets are opened gingivally. Okay, so you take a look in the mouth of the patient. You don't need to take a look in your computer or documentation, whatever. You see immediately that what type of braces. Remember, because the door has a cavity in it, and the hooks are smaller with the PIS 21, and so you see which torque you have used, how you bonded the pliers, and you close the brackets like that. Okay, so vertical flipping is called flocking on the upper frontis if you do that from canine to canine. And so we flip the brackets. It's not a problem if the hook is pointing downwards. -9, -6, and on the laterals, and -12 on the centrals, and then close them. Okay, so as we don't have time for separate slides today, so when we do flipping and when we do flocking, okay, we do flipping whenever you have the slightest doubt that you could have protrusion on the upper incisors. You flip the brackets, okay, even if you have the slightest doubt, okay, even if it's just a little bit of protrusion or a little bit of crowding, or not severe crowding. Okay, usually it's enough from on the incisors. Okay, remember, protrusion happens very fast. Okay, so it's better to keep the teeth upright, and even if it's necessary, actually it has, maybe it's very rare that it happens, that, or I add a little bit of buccal crown torque on the incisor if I need to, or I re-flip the brackets, so re-invert, reposition the brackets. I flip them back, but I do it very rarely. So usually I go till the end with the original torque selection with my cases, because many times this is a question, if I do that or not. So anyway, so basically, if you are in doubt, and there is a mild crowding or mild protrusion, you flip the brackets on the incisors. If there is a more severe crowding, and even if the canines are not inclined vestibularly, the crowns, then you flip the brackets from canine to canine. Also, if it's a class 3, then you flip the brackets on the incisors to avoid the protrusive side effect of the excessive class 3 elastics. Okay, and the lower, this is the normal, +9 on the canines, -6. Remember, it's minus on the incisors, and this is how you close them. And when you flip the lower incisors, okay, we never flog the lower lower frontis. So if you flip, then it's going to be, they're going to open gingivally, and it's going to be +6. Okay, the torque. If there are spaces, or we use class 3 elastics. Remember that. Or for whatever reason we wanted to protrude the lower incisors. So the simplified torque selection of Dr. Pitt, we have no variable torques. We use the same inventory, which is greatly reduced. We use the simplified approach to torque selection. It minimizes the wire torque bending, and it's very efficient with the active early progressions. I will talk about active early a little bit later. Okay, 32 years old female patient. I'm just going through this case again. Yes, you can see she's opened at the front. Okay, she's a full step class 2. She was told to have orthodontic surgery, and I corrected the case only with elastics. Okay, we did expansion in the upper and lower arches, upper teeth are protruded. And the only thing that she's a long face type, so I already explained to her that, look, I'm going to have extrusion on your upper front teeth so you can become gummy. And she was already a little bit gummy because she could have, smile a little bit wider than in this picture. But she told me that's fine, and I don't have any problem with that. I want to put TEDs in, two upper TEDs, but then it happens that because that's like the diffuse, they tell me, no, I don't want that, doctor. I don't care if my gum is visible a little bit. Actually, in her case, that was her husband. So anyway, we started with V elastics, inverted V elastics, to start to close the bite down and correct the class 2. As well, we did put this articulation on the upper 6 because if it's a deep, if it's an open bite, we put the disarticulation on the upper first molars because the intrusion is much more effective on the upper first molars. And we also use squeeze exercises for the intrusion, which means that the patient puts his hands like that on the musculus temporalis, and he just pushes together the upper lower teeth and squeezes like tuck, 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 very fastly, tuck, 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 like that, 60 times 60 per day, and it really we can have 1-2 millimeters or even more intrusion on those teeth with the squeeze exercises. All right, low torque flip brackets in the upper incisors because of the protrusion, and it also helps us to close the bite down. When it's an open bite, class 2, I don't use the upper 4 lower 6 elastics, but upper canal and lower 5 rather to collect. And we also use the rainbow elastic on the front teeth to close the bite down. She's also seen by type, so you can see that she had some issues, some popular recessions during the treatment. We are getting close with the stainless steel arch fibers with the hooks to class 1. I changed to class 2 disarticulation to help to move forward the mandible, and these are her finishing elastics. We did IPR on her and some recontouring just because of the black triangles, finishing elastics, and it was 21 months, I'm sorry. This is the final result. Perfect class 1. The only thing I would say that obviously she shows more gum than I would like to see, but she was happy with that, and it showed me that there is no way I could put in her test. But I think anyway, it's really looks really great, and with aging, her upper lip will come down. Okay, these are the before after. Just goes through very fast, and this is. You can see how you can change that without rapid palatal expansion or any palatal expansion, how you can change with the Pitt's broad arch fibers, arch form, how we manage to change the arch form of the upper arch. And remember, in class 2, this is your shoe has to be big enough that your foot can fit into it. Okay, in other words, okay, and these are before after and seen by type, and you see how nicely we managed to correct her the black triangles also. Okay, arch forms. Broad, this is what we use the most. It's broad. Okay, we use the standard sometimes. I use a standard when it's a class 3 case. Usually the upper arch is very narrow and the lower arch is very wide, so I use standard in the lower and broad in the upper. Okay, in class 3 cases. Or if it's a Symbiote type, then I start with sometimes the standard wires, and then I use the broad wires, though it's never really an issue. It's not really an issue with the Pitts 21 and with the square arch fibers because the forces are so gentle. Okay, so mostly we use Pitts broad. The arch form obviously ensures broader smiles, nice expansion, so it gains space with transverse arch development, so it helps us to avoid the protrusion, remember that. Improves efficiency with the actively arch fiber progressions. I'm going to talk about it in a second. We need less arch fiber bendings, and it really simplifies an extraction treatment. Active early, over 14 night tie, 18 by 18 ultra soft night tie if we can start with that, then 18 by 18 night tie, then 20 by 20 night tie, then 19 by 19 stainless steel if necessary, and then 20 by 20 beta titanium. It depends. Many times I finish my cases on stainless steel. Sometimes I jump from 9-time to beta titanium, or not sometimes, many times. But it depends, obviously, on the in what stage are we with the treating the malocclusion. Okay, so what is the pizza active early fire sequence? If we have to start with up 014 night time, we start with that with 4-6 weeks. Okay, those who are new, then it's better. You can see your patients every 6 weeks, no problem. I'm pretty experienced, so I see every 4 weeks my patients. When we can, we start with 18x18 utas of night time, because obviously it's a square wire, so it's not a round wire. So in other words, we have immediate torque control on the fronties. 70-80%, no, actually now it's 80-90% of my cases in the upper arch, I start with 18x18 ultras of night time, because I want to control the torque as soon as possible. If I have an ectopic tooth or ectopic teeth, then I bypass them. I use open coil springs. I will show you a case for that soon. Okay, so 80-90% in my cases in the upper, I start rather 90. I would say today. It was like half a year ago. It was, or a year ago. It was 70%, but now it's 80-90%. So again, I want to control the torque as soon as possible. The 18x18 ultra soft night tie is a very, very soft wire, almost as soft as the 014, almost. Okay, and basically 50-60% of on the lower arch, in 50-60% of my cases, I start also with an 18x18 ultra soft night tie. Okay, so when you can, you have to start with 18x18 ultra soft night tie. Okay, then use the 18x18 night tie for 4-6 weeks. Then upper and lower 20x20 night tie. Usually I put it in for 4 weeks. Then we have the plenary appointment. Okay, when we take a Panorex and we decide according to the position of the teeth that what we need, and root angulation, rotation, whatever, display, vertical visibility, whatever. And we reposition the brackets. We remove the brackets and we reposition them. And then we reinsert the 20x20 night tie. Usually, for me, it's never necessary to go back, to step back to 18x18 night tie. But if you have to, you can do that, okay? I always try to be as precise as possible with my bonding, okay? So with good, a perfect or very nice treatment, or a great treatment starts with great bracket positioning, okay? So I will always give the time, and I encourage you to give yourself the time to bond. It's not like boom, 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 boom. Don't bond like that, okay? It's because it's not going to be effective. All right, so panel repo, 4 weeks 20x20 night tie, then you do the panel repo, then with 20x20 night tie goes back for 4 weeks. If necessary, step back for 4 weeks, 18x18 night tie, then again it's 20x20. Then you go forward and you insert upper and lower 19x90 stainless steel wire. If I want to have more expansion, or if I still have a sagittal discrepancy, then I go for stainless steel, and then for my finishing I put beta titanium. But in many cases I also bend my arch wire, my stainless steel wires, because they're really soft. Just take in your hands a 20x20 night tie wire and 18x25 night tie wire. You will see that how much stronger, stiffer the 18x25 night tie. It's really worth doing that to experience. So anyway, stainless steel, 19x19 and 20x20 beta titanium. We used to start with 20x20 stainless steel. Especially with flip brackets, it was too hard on the teeth and for the patients many times. I still use 20x20 night if I want to have more expansion, okay? And 19x19 is not enough. There are cases for that. Okay, I see the patients every 4 weeks, okay? If it's extraction or space closure, I use 19x19 stainless steel, and I see the patients also 4 weeks. So remember, the take-home message from the pizza active early arch fire sequence is that if you can, try to start with 18x18 ultra soft night tie, not with 014 night tie. If I start with 014 night tie in the lower, usually really I never start with the upper. Only 18x18 ultra soft. So in the lower, after 4 weeks, then you change for the 18x18 ultra soft. So as soon as possible. So maximum 4 weeks. Okay, and the pizza active early philosophy. What does that mean for For arch fires, with the 18 by 18 and later by 20 by 29 arch fires, we can control much earlier the torque and expansion. You know, it's really very, very important to control the torque as soon as possible, and remember not to have the boom protrusion effect. Let's call it, yes, it has just come to my mind, boom protrusion effect, yes, because it happens like that. And remember that when I start on the upper arch with 18 by 18 ultra soft, then 4 weeks 18 by 18, then 8 weeks 20 by 20. After 8 weeks, I already inserted my biggest arch fire. What a big difference, right? Huge difference. And then after 3 months, I do my panel repo. So it's really good. Very, very good. Okay, 15 years old male patient. Let's see how we solve crowding. Okay, crowded case, class 2 tendency. And yes, definitely we have crowding. Okay, here. So what we do bypass the ectopic Ds, and we put the coil springs there. Okay, low torque brackets, obviously, standard brackets with -6 in the lower arch. Okay, through the bite class 3 elastics. Okay, we use through the bite class 3 elastics. We start even if the patient is a class 2 case. Okay, I repeat, we do start with through the bite class 3 elastics. Also, if the patient is not only a class 3 case, but a class 2 case. Because if a class 2 case has crowding, number one. Number two, if the crowded case has, I'm sorry, number one, if the case is crowded, okay, and we still need to create the space. So we need to, you know, have some, let's say, distalization effect on the lower canines, and we need to create the space, okay? And or if we don't need to, we don't have crowding in the lower arch, but the teeth are protruded, the lower incisors are protruded. You know, it's like as soon as you don't have your overjet, so you have to upright those teeth first. I'm talking about the class 2, and then you start with class 3 elastics. Then, okay, because with the pseudo-bag class 3 elastics, you have expansion of the upper arch, okay, and then you correct or upright your lower incisors, and then by creating the overjet, then you change to class 2 elastics, and then you move forward everything. This is very important to understand. And even he's a deep bite case, but you see, I put on the upper 6 the disarticulation quite big because I wanted to give him more display. Okay, I wanted to have the clockwise rotation on the maxilla because the rotational center of the maxilla between the upper 5 and upper 6. But again, we don't have time for that in details. So 1.5, we open the coil spring with 1.5 bracket width, okay, not more. You see, this is very lightly activated, okay? I'm sorry, my magnification is not working now on my Mac, so I just can't show it to you closer, and it's really slowed down now. But anyway, so it's, you see here, okay? It's not you know, not light forces through the bite class of elastics, okay? And just like that, okay? This articulation, and the total read was 18 months, and this is the final result. I just want to show you, yeah, how we did create the space, the upper arch. You see, palatal buttons in the upper 5 and the coil springs. And then when you have more space, not enough space is more space than you would think, then you insert an 014, obviously, for 4 weeks, then to start to move those teeth. But when you have already with the torque control, the upper centrals, then if you insert an 014 night type for 4 weeks, that's not a problem, okay? It's not going to protrude. Or another hint that you can help with your, even if it's not an open bite case, with rainbow elastics, you can really control really well the protrusion of the, or against the protrusion you can fight with your rainbow elastic. Lower arch, the same thing. Obviously no lingual buttons, but just like that, you know, it's like coil springs, opening the space, and with broad arch form, you know, a little bit of, it's called retrusion chain, lower, and that's it, you know. And this, and you see the lobular surface of the upper central incisor, come on, yes, right here, is perpendicular to the front foot horizontal plane. This is our aim, right? And that case was, there was plenty of crowding, right? This is the final result, okay? Good. Disarticulation is our next topic. Okay, we just, it's almost 2.5 hours now. So we're running out of time a little bit, but don't worry, we're gonna finish. Disarticulation, posterior bite buttons we can use, or we can use anterior bite buttons. So I used to use more anterior, now I use more posterior. On the upper first molars, we put them. If the visibility of the upper front teeth is not enough, remember clockwise rotation of the maxilla. Okay, more display. On the upper first or second molars, with an open bite case, or class 3 open bite tendency. Okay, because we need intrusion and squeeze exercises. In other cases, we put them on the lower first molars because basically that is the most stable place, let's say. If the overjet is big and the bite is deep, again, if the overjet is big and the bite is deep, on the lower second molars we put them, okay? Many times, no, actually most of the times I can tell you, remember I treat a lot of the class 2, so deep bite, big overjet and big curve speed in the lower. I never use anti-speed curve wires, never ever. You know why? Because they, by this form, with this form, the front part is like that, so it's going to protrude the lower incisors. As soon as you lose your overjet, your class 2 correction is over, game over, okay? You have to keep those teeth upright, those lower front teeth incisors, otherwise you lose the battle. No, I mean, you lose the war, not just the battle, against the class 2 correction. So anyway, if the overjet is big and the bite is deep, on the lower second molar. So what I do that, normally we cut the O1-4 arch wire behind the 6, okay, because it's coming out very easily from the 7th tube. And it doesn't matter if it's an open bite case or deep bite case or whatever bite case, I bond the brackets from 7 to 7, always. So I'm not afraid to bond the brackets on the 7s when it's an open bite case. Okay, so what I do, that in the lower arch, let's say we have crowding or whatever, we start O1-4 till the 6, okay? This articulation on the lower 7s. O1 18 by 18 mutasoft till the lower 6. 18 by 18 till the lower 6. What's going to happen with, let's say, class 2 elastics or box elastics? We're going to have extrusion on the lower premolars and molars, okay? And there will be always a vertical jump between the 6 and the 7s. And you keep, adding to the disarticulation, obviously. And then with the 20, when I arrive to the 20 by 20 phase, I go till the 7th. Okay, sometimes I leave on, sounds strange, or sometimes I change the disarticulation, or most of the times, I changed on the upper first by cuspid. So then I have my vertical dimension, and I can, lift up at the level of the lower 6, the lower 7s. If it's necessary, you can use some box elastics on the lower 6 and 7s to have that. Okay. We do 1.5, 2 millimeters of bite opening, and we do it right from bonding. As I do say, anyway, we could talk a whole day about just disarticulation, okay? Because there are so many ways to do that. Okay, anterior disarticulation bite button. If the visibility of the upper teeth is good, okay, so we don't need extrusion, let's say on the front teeth, or rotation of the maxilla. In deep bite or cross bite cases, they are useful on the upper canines and later on the centrals, because if you start with them on the upper canines, and what's going to, if you start with them on the upper centrals, what's going to happen? Not going to have, the expression of our SAP bracket positioning. The smile arc is not going to be really good. So we start on the canines, and then when we arrive after the night tie wires, we arrive to the beta titanium or stainless steel arch wires. Then we change them to the centrals. So I usually put them on the canines. It helps for the intrusion of the upper front teeth, so it can help with the gummy spine cases. If not, you put 2 tests between the laterals and the canines, then you intrude the whole frontal part of the upper arch, or if it's necessary, put at the back both palatally and vestibulary. So with 6 tests, you can just intrude the whole maxilla. In class 2 cases on the upper first molars, we put them, and on class 3 on the lower molars, because when you arrive to the phase when by correcting the lower the anterior cross bite with the moving backwards distally the lower incisors, then you have an edge-to-edge contact, and then you need the lower incisor disarticulation. the most important things about that it has to be at the height of the incisal edge, okay, because otherwise it's not going to slide forward from the crossbite situation. Difficulty of eating and speaking, patients have it, and with the anterior ones, but I use like 80% posteriors now, and yeah, or no, 60-70% posteriors and 30-40% anterior bibuttons. And obviously we change the position mostly from the lower 7 to the upper 4 in class 2s, okay, or from the in class 3s from the upper 6 or upper 7 if it's with open bite, and then to the lower incisors. Okay, so you have to change the position of the when it's necessary, and you have to keep monitoring of the disarticulation. Okay, it's very important at every appointment. Right from bonding, 1.5 to 2 millimeters bite raising. Okay, 24 years old female patient. It's a class 3 case. Just going through this, and fortunately I didn't have to use 2 TEDs because 2 lower, this is the anterior crossbite, and 2 lower molars were missing. We had some hygiene issues with this patient and during the treatment, and at the end the lower molars had to have fillings. But this is an orthodontic surgical case, and she was told orthodontic surgery everywhere. And we started disarticulation in the upper 7s because the 6 mostly in most of the cases are in edge to edge or crossbite, whatever. 7s many times are in good position. So on the 7s, this is our base point, or these are our base points for the disarticulation. And then through the bite elastics, I started with 4 elastics on her between the upper palatal buttons and the lower teeth. You can see here a low torque brackets because of the and I didn't flip the lower incisors, but you have to flip them, okay? And because I just wanted to test the capacity of the ability of the pit-sternum braces. And now later than upper 5 palatal buttons, okay, here, and the lower canines, okay, so because we need expansion, always remember, and you can use broad in the upper and standard in the lower, in these type of cases, arch form, and expansion and class 3 vector. Then later, on the left side it was class 3, and on the right side it became class 2, and then we started to mesialize the lower molars. We use lingual buttons for that, okay, and it was class 2 elastics after we corrected the class 3. And the total treatment time was 28 months because of the mesialization, and occlusion is good. That we just had some issues, so she needed on the lower molars new fillings at the end of the treatment. Okay, and you see that how we managed to correct the upper arch, just the rotation, alignment of the teeth. Yes, at some point we had 3 palatal buttons on each side. Then we played a little bit with the disarticulation. We repositioned them on the upper centrals because she got into class 2 from class 3, but it was I expected that because of the missing lower first molars. So this is the development of the upper arch treatment, and this is the lower arch treatment, and those molars were extracted when she was a child. So you see that the bone is so much more narrow there. And then we started with the mesialization on the left side, and then later on the right side. And yes, she had some issues with the hygiene. Vestibularly close coil springs, lingually the buttons, or you can put Capling hooks as well, and with chains. Okay, and that's it. Nice overbite, overjet, and this is the before after. Okay, and she's huge change in the profile, and obviously in the smile. Okay, just like that, and nice display. Okay, interarch elastics. We call them immediate light short elastics. And because we use them immediately, so from the beginning with this articulation together, okay, we need to take out the teeth from the occlusal forces with the disarticulation, and we correct many things with the elastics. We use light forces and short distances. With the knitted arch wires, we use 2.5, 3.5, so we call them light and medium elastics. Obviously, the diameter depends on what teeth we use them, but usually we use 316 elastics for class 2, class 3 correction, and also we try for triangle elastics, and we use 516 light elastics always for the rainbow elastics to avoid the root absorption on the front teeth. With the beta side titanium, so night arch wires 2.5, 3.5 ounce elastics, and on the with the beta titanium stainless steel arch wires we use 3.5, 4.5 ounce elastics, and continuous wearing patient cooperation, very important. Right at the first consultation, we explain them how important is that, and we always emphasize that the promised treatment time, the length of the treatment which we promise, it's also only can be guaranteed. It's only can be guaranteed. With the continuous wearing of the elastics. Okay, I always tell them, look, we are the same team. Okay, we do, make your teeth move, and you also make your teeth move by brushing your teeth and by wearing your elastics. So and we are going into the same direction. 2.5 ounce light, 3.5 ounce medium, 4.5 ounce heavy, and we never use basically 6 ounce extra heavy because it's not necessary, light forces. And this is one of my favorites from my dear friend John Campbell from Canada. Elastics are your treatment. This is for the patients, obviously. And we use the intermediate light short elastics in groups from day one. Just a couple of examples. So class 3 elastics, upper 5, remember it's usually palatal buttons on the upper 5 and lower. So through the bite, we call them through the bite class 3 elastics and lower canine. Just one hint, when it's a deep bite case and it's class 2, I start with upper 5 palatal button and lower 4, okay, because I need to have some extrusion on the lower teeth, and later I can change to, when I started to align the lower curve of SPI, to my lower canines. Upper 4, lower 6, I use through the bite, so palatal buttons upper 4 if it's a class 2 case and we don't have crowding on the lower front teeth, or they are not protruded, so we have the overjet to correct class 2. They are 3/16s, and on the anterior teeth we use the rainbow. This is a class 2 anterior rainbow, upper centrals and lower laterals, or they could be lower canines as well. There is nothing wrong with that. It's always 5/16 light to avoid the root resorption again. And class 3 anterior rainbow, because it has a little bit of more class 3 direction, upper laterals and lower centrals, or they could be upper canines as well. Okay, and just one more time, a hint again: if you use rainbow elastics on the front teeth, when you unravel crowding, it's very, very good against protrusion of the teeth. Okay, so you can wear it, have it worn by the patient full time. This is a class 1 finishing elastic. It's just upper 6, lower 6, lower 5, and upper 4. This is when we have a class 1. Okay, it's class 2, it's upper 6, lower 5, and upper canine, because it has a little bit of class, not just sucks together the teeth, but it also has a class 2 vector. 5/16 light during the day and medium at night. This is how I use them, all of my finishing elastics. And class 3 finishing is just one step forward in the lower arch, upper 6, lower 5, lower 4, and upper canine. And again, 5/16 light during the day and 5 medium during the night. Okay. 46 years old female patient. So this is about the elastics, just in briefly. And the most important thing is really just full time, and really wearing them full time, and really they don't really feel it. Okay, I was wearing them for 22 months, and I was lecturing like this, my elastics and with my elastics. So it's no big deal. You just have to explain to the patients that how their experience will be by wearing the elastics full time, and they shouldn't be worried about it. 46 years old female patient, crowded case, class 2 case. We had only 3 incisors in the lower arch, and perio case also. So we had to be careful, but she didn't want to have implant on the lower left side, and obviously she hated her smile, so that was the reason she came. And coil springs again, low torque brackets because of the protrusion, open coil springs to create the space. Sometimes, or not just sometimes, many times, if we have crowd injury, we just put them between the canines, lower canines. Then, like it could be not 3 times 1.5 bracket width, but let's say 2-3 brackets width, because of the period situation. We had to be careful. Through the bite class 3 elastics, you can see right there, okay, to have expansion in the upper arch. Palatal buttons there, this articulation, because I wanted to give her more display. And I put on the upper 7 on the left side because she didn't have the 3-6, so in the opposite arch on the upper 6, it wouldn't have made any sense to put there, because it couldn't work. So that was the reason I put it on the 7th that side. Later, class 2 elastics, and then I put a teddy into we mesialized next to the class 2 elastics. Again, I'm sorry, we mesialized with the class 2 elastics the lower teeth and the lower molars, and total treatment time. It takes usually 20-24 months to mesialize the lower. And nice gum situation. We did IPR to correct. Obviously, we were not able to fully correct the black triangles, but we managed to give her really a much more beautiful smile. This is the upper arch development during the treatment and alignment. You can see. And the Pitts broad arch form we used after the IPR. Obviously, I put between the canines and the 6-8 ligature, and from canine to canine power chain to close the spaces. This is the lower arch, which is more interesting, let's say, because of the mesialization of the molars. First, we didn't use, only later, lingual buttons. Okay, it is not their favorite. I have to be honest, because it disturbs the tongue a lot. And then, when even if it doesn't, the second molar doesn't follow the first molar. The third molar doesn't follow the second molar because the first molar was missing. So then it comes forward very fast after, because the bone is so soft, becomes so soft that it comes very fast. Obviously, we had continuous control, and you see that the situation was still good, and periodontal from the periodontal point of view. Okay, and this is her final smile. Now she can really smile, and I think it's a gorgeous smile. I told her that you can go to the aesthetic dentist to correct those remaining black pepper spots, but she told me no, I don't want to do that. Okay, my oldest patients, I have just bonded. She's a doctor, and she's 62 years old. So, and probably we'll see that case in the future and finish that. Okay, panel repo case management appointment. Okay, it was introduced by my dear friend, Dr. Jim Morris, and it's a critical read and react point of the treatment. We do a re-evaluation of the treatment, and evaluation of the occlusal changes, and evaluation of the aesthetic changes. So we examine the occlusal changes as number 1. We examine the alignment, the leveling and overbite, the anterior-posterior relationship, the transverse development, and the occlusion. Number 2, examination of the aesthetic changes. So we examine the spine arc, the buccal corridors, the axial inclination of the teeth, front teeth. Remember how important 18 by 18 ultra soft to start with, the arch development to have 2 smile, and the alignment of the teeth. So with this treatment evaluation and reaction, we change what needs to be modified to have the planned result, both from the aesthetics point of view and from the functions point of view. So we do bracket repositioning when it's necessary. Okay, so it doesn't matter if it's an angulation necessity of angulation changing, or vertical changing, or rotation, or flipping brackets. Okay, so we can change the torque. If you are in doubt, even if you arrive to the panel repo appointment and you bonded normally with normal torque your upper front teeth or the incisors, and you are in doubt, I might having a little bit of issue with protrusion, then flip the brackets, okay? Use low torque. But it's better to start with low torque, okay? Because remember, protrusion happens very fast, but if you start with low torque, and even if teeth are too much uprighted, too much upright, then you can release them. You can flip back the brackets later. It's much easy and much less time consuming. So incisors and cuspids variable torque selection. So you can do flipping and flopping where it's necessary. You can do changes in the biomechanics where necessary. So you can change the way how you use the elastics, or the patient uses the elastics. You can change from anterior biated bones to posterior ones, or from posterior ones to anterior ones. So basically, yes, you have to react what's happening in the mouth. So basically what we do is the treatment planning for the second part of the treatment, okay? And remember, even after 3 months, we are there with the PITS-21 braces. Okay, so the PITS-20, PITS active early philosophy, basically, what does that mean? That today we want to activate the appliance as soon as possible, right from the beginning, bonding, using a combination of smile protection bracket positioning, flipping brackets, so using low torque, in other words, disarticulation, changing of its position, immediate line short elastics from the bonding, active early archway progression with its broad arch form to catch a couple earlier, in other words, to have the torque control as early as possible in the treatment cycle while developing the arches transversally. Okay, so we do everything at the same time. Okay, we expand, we start to correct the crowding, we start to keep under control the torque situation. We remove the articulation forces with the disarticulation, so we are able to move into the right direction, the occlusion, and we can have the arch development. So it's very, very important. One of the advantages of the active early case management is that improvements in both the aesthetic outcome and the functional occlusions occur simultaneously, rather than sequentially, as in many other approaches. It's really very, very important, and I would like to underline 3 times, is that everything we do simultaneously. And this is why we are really, really so effective with our cases. All right. We can move the teeth in 3 dimensions, but we have to consider another factor with our treatment planning. This is the so-called 4th dimension, which is time. Okay, and time means facial aging. Okay, face aesthetic changes. Unfortunately, we are not like Benjamin Button, that we born like on the right side and we go into the left side, but it's the opposite. So nothing gets better. Believe me, I will be 53 this month. So believe me, with aging, nothing gets better in the human body. Mentally, we can get better, and we keep trying to be, but physically, it's not like that. And our face is aging. So again, we don't have more time to get into more details with the facial aging, but you have to know that with extractions, you can really have a negative effect on the face. Okay, we do extract teeth with the PITS protocols when we have biomaxillary protrusion. Okay, or we put TEDs in and then we retract the whole arch, or arches, the upper and lower. But if you they did extraction. This is not our case, not my case, or neither Dr. Pitz's case or Dr. Wasimbuzi's case. But for this young lady, they extracted 4 bicuspids, and in her 20s, they made facially like her own grandmother. She became so. This is, and I did it. For many of my patients, unfortunately, before my 2004 life. So, but what we need retention for life, okay? Because the research is clear, all alternative treatment is unstable, whether it's treated with extraction or non-extraction. The research also shows that with fixed and removal retainers used accordingly, we can maintain the result. We need that, okay? So what we use upper and lower front, on the upper and lower front is fixed retainers. Normally on the incisors, or if we had crowding from canine to canine, and on the lower arch, it's always from canine to canine. We use upper and lower S6 retainers, and we use muscular retaining splint after sagittal discrepancy. Basically, two S6 splints, which are retainers, which are attached together. Okay, and I'm sorry, just like that. And I asked my patients to wear the removal retainers. They sleep with the splint 12 hours per day. I mean, with the splint and with the S6 retainers together for 4 months, then 10 hours, then 8 hours, which means one night with the splint and the other night with the splint and the other night with the S6 retainers, and then in the second year every second night and then every third night. Then so we basically leave them, but I still tell them to wear once or twice per week later, just for to make sure everything is great. Okay, 3D digital smile design in orthodontics. Yes, we can have smile design in just a couple of slides. So we can plan aesthetically what, from the aesthetics point of view, what would be the most ideal result for the patient. We take videos just to see the dynamics of the smile of the patient and the face. Dynamics means that obviously when we ask them, when we take our photographs, that okay, smile, and they are not, they are not socialized simply to be able to smile. So they just they don't want to show their teeth to us, and so it's not their real smile, in other words. So this is his real life, real smile, I'm sorry. And this is his real smile, so we can see that we need some extrusion, more display for him, so we can position the brackets higher, we can change the bracket position according to that, and we can plan the biomechanics that according what width we need with our expansion, where we need to get to, and we can project our digital smile design during the treatment on the teeth, and so we can decide if we have to recontour the teeth or reposition the brackets, or where we have to use our lasers and so on. And it's really nice to have this virtual simulation for them, to show them how their smile could look like. Okay, so this is a great thing. And also I also use my laser. This is one of my assistants. She's at home now with her baby. But it's like right before the end of her treatment and after we did the crown lengthening with the laser, and it's really a whole different world. Okay, actually we have 2 more patients. Okay, I will just show you this just the before afters of this class 3 case. Okay, and so her lower midline is right here. Okay, you see right here, this is the upper midline is correct. She's a class 3 patient. She was thought to have orthodontic surgery. This is the final result. It was almost class 1 on the, let me show you with this, almost class 1 on the right side. She's a full step class 3 here. 2.6 was missing, so we mesialized upright and uprighted and mesialized 2.7. And this is a full step class 3 here. Okay, and then only with elastics we managed to correct the class 3. Upper 6 upper molars disarticulation through the bite, class 3 elastics, crisscross elastics, and this is the result. I mean, the before afters. So in summary, we have the most precise PSL bracket system. We have a simplified torque selection, as you have just seen. We use the spinal protection bracket positioning. We use the Pitts broad arch wires. We use the Pitts active early arch wire sequence. We use disarticulation, anterior, posterior. I have just forgotten to tell you that obviously 2-3 months before the end of the treatment, we remove the disarticulation because we need to put in the occlusion dose teeth as well, where we applied or used the disarticulation on the last teeth. What had the disarticulation. We use immediate line short elastics throughout the whole treatment. And we have just started to use dental monitoring, which is a great thing. The patient has basically mouse opener with a scan box and with an app, and his or her mobile phone weekly scans the teeth, and we can really monitor. The software, watches more than 180 parameters, and basically virtually they can take home their, as one of my assistants told that for the first time to one of our patients, that you can take Dr. Csiki back home with you virtually, so he will be always with you. So and it's amazing. It's amazing control. I always dreamed about it, and that I could see so often my patients. And if there is open the door, or there is gum inflammation, or there is caries, or the aligners don't fit, and the patient is not able to move to the next liner. So it's a fantastic help. Okay, this is my favorite PITS-21 case. 16 years old female patient who arrived to me with an open bite. It's class 1 on the left side, and it's a 4-step class 2 on the right side. We did obviously some arch development for her. This is a skeletal open bite case. She was told to have orthodontic surgery by 6 orthodontists. And obviously I told her and the parents that during the treatment we should have probably TEDs by closing the bite down, because it's always becoming the patient in these type of cases more gummy, and we don't want to develop a gummy smile. But also on the other hand, it's also true that by using the light forces and the accommodation or the rehabilitation, or how to say, the muscular balance or the muscles on the face, result in having, the upper lip comes down many times even after we finish the treatment. So this happened also in her case. So at the end we didn't have to use TEDs, but at some point I was there to use TEDs, and I flipped the brackets. And because of the crowding also, and it's easier to correct the open bite like this. On the upper 7s we put the disarticulation, because on the 6 it was edge-to-edge occlusion. Through the bite class, through elastics we started with, and with rainbow elastics. Okay, so we started to close the class 2, and also we needed to expand in the upper arch. And you believe or not, after 6 months we got here. Okay, after 6 months with the PITS-21. So we closed the bite down basically, and we corrected almost corrected also. You see here on the right side the class 2. This is the, remember, upper 3, lower 5 class 2 elastics with open bite cases, and these were her finishing elastics. And you can see that nice Pitts broad arch form we managed to have. And this is the big surprise, that it's, and you can see how effective really with 3-dimensional control and with light forces, and that we are still faster than ever before with the PITS-21. So in 16 months we managed to finish our treatment. This is the final result. I did some recontouring on her teeth, and in this video you can see how we managed to align and correct the upper arch, and it's a nice Pitts broad arch form. And just from the start till the end, and from the canine to canine, the fixed retainers, no root resorption, you can see, and the x-rays, and the skeletal open bite is over. You see that we have a nicely upright incisors, and as I told you, her upper lip came down, so we had a really great result, and just 16 months. And the mother told me that unbelievable, it's really unbelievable for everybody that she was told to have orthodontic surgery. So I can't thank enough to Dr. Pitts and Dr. Brown, who keep helping me and helping us to achieve these results. Without them, I wouldn't be able to hear the lecture for you. So as always, it's been a great pleasure for giving you a webinar. I feel a little bit sorry because it was rather a beginner webinar, and I know there are many doctors who are already in advanced level, and they are here today. So thank you very much for all of you to be here. We learned from Dr. Pitts that orthodontics is not a science but an art. I truly believe that. And thank you very much for your attention. I look forward to seeing you next time, hopefully soon, second part of this year in person. And if you, I'm getting more and more busy, but you can write to me on peter.chiki@orto@gmail.com. This is my email address. And so if I don't answer, just you can shoot me, in a week, then shoot me another time. It's been a pleasure to talk to you to 3 hours. I hope you managed to have some valuable information from my lecture, and we look forward to, and also from Dr. Wasim's lecture, and also we had another lecture in Spanish. So thank you very much again. We don't know yet. Our European Pinnacle is cancelled now, obviously at the end of June, because of the pandemic is not possible. But we keep working on it to with Ortho Classic to have it as soon as possible. And till then, take care and stay safe and have a great weekend. And I hope to see you soon, everybody. Okay. Thank you very much for your attention. Thank you. Bye bye.